A very good evening to all the doctors and the faculty today. Today, we are privileged to have a very important webinar on a very hot topic, COVID dilemmas in OBGYN. We have the GM Marketing and Sales of Alembic, Miss Artika Rajpal, who will be taking over now. I request her to continue the session.
Thank you so much, Meera. At the offset, I welcome you all on this lovely Sunday evening. Alembic has always been on the forefront in partnering with doctors to provide scientific updates. One such mega initiative was the Knowledge Beyond Boundaries, which was launched last year, which saw a plethora of national as well as international KOLs speaking in different aspects. The most attractive part, apart from the national and international faculty, was the format and the content. So here we are, last year when we completed 5 Knowledge Beyond Boundaries, which attracted doctors at a tune of 6,000 plus in each of the CMEs. This is our sixth series of Knowledge Beyond Boundaries. At the offset, I would like to thank Foxy to give us a chance to collaborate and bring to you this lovely CME this evening. With this, I would like to hand over to our moderator for the evening, Dr. Komal Chavan. If I can have the slide, please. Yeah. Dr. Komal Chavan is a known face across India. She is the medical director of Chavan Maternity and Nursing Home. She is also the honorary professor at Cooper Hospital and HBT Medical College, Mumbai. She also is the chairperson of Foxy Medical Disorders in Pregnancy Committee. She has also won numerous prizes in her career. With this, I hope you all enjoy this lovely evening with the topic of COVID in pregnancy. So welcome you all once again. And with this, I now hand over to Dr. Komal Chauhan. Thank you so much.
Thank you so much, Artika. And I welcome you all on behalf of Foxy Medical Disorders in Pregnancy Committee for a very important topic of these times, that is our COVID times. And COVID, we are in the second wave of COVID. And so many patients are coming with different symptoms. The symptomatology has changed. The effects on pregnancy are being observed, varied everywhere. So all these COVID dilemmas are something which we are going to discuss today. And I would really like to thank all the esteemed faculties from all over in India who have joined our partners Science Integra and Alembic. And I take pleasure in inviting Dr. Alpesh Gandhi, Foxy President, who has been a support and always encouraging us to do the webinar. Also the Vice President in charge, Dr. Atul Ganatra, Dr. Jaideep Tang, Secretary General. Deepest gratitude to all the office bearers who have always encouraged and supported the committee to come out with these different topics of the webinar. And now I would like to introduce Dr. Alpesh Gandhi, the chief guest for today. Dr. Alpesh Gandhi, as we know, can I have Sir's slide, is the president of Foxy. He was formerly the vice president of Foxy in 2013, governing council member of ICOG, chairman of Practical Obstetric Committee, Foxy, and has adorned several hats in all the numerous organizations all over India. And basically, he is well known for the critical care in obstetrics. He has series of these workshops, and he is very instrumental in making the HDU and IC, all HDU for the obstetric patients possible. He is still working on it, and with his visions of safety first, he has done fabulous work as a president in this pandemic. Though the digital platform was available, but he has done wonders on the digital media. So over to you, Dr. Alpesh Gandhi, sir. Thank you so much for joining. And can I have your 2 lines of encouragement for the program? Thank you so much.
Thank you, Dr. Komal, for this very, very important webinar and inviting me as the chief guest. Very good evening to all of you. At the outset, I would like to congratulate Medical Disorder in Pregnancy Committee, Foxy, and Chairperson Dr. Komal Chavan for doing excellent work in this difficult time of COVID-19. Since last 1 year, I have seen working very well. The committee is working very well throughout the year on all the fronts. I also would like to welcome our guest of honor, Dr. Rishikesh Pai, incoming President-elect 2020, and a very good friend of mine. We have a very good eminent three chairpersons, Dr. Archana Verma, Dr. Ranjana Khanna, and Anand Bagde. A very good evening to all of you. And we have a very interesting topics: antenatal care in COVID, fertility management in COVID, and COVID vaccination, and women health, going to be covered by Dr. Bhaskar Pal, Dr. Ramani Devi, and Parikshit Tak. So we have, and then we have a panel discussion COVID in pregnancy, do's and don'ts, with eminent faculties as a chairperson, as panelist, and it is going to be moderated by Dr. Komal Chavan. So very, I can say, galaxy of speakers, eminent faculties, and very good topics. Today we will have a very interesting scientific deliberations. We can say it has been over a year since COVID-19 pandemic hit us, and overnight change life as we know it. As doctors, we have been on the front line in this war, and I can say we can use the term that this is the third world war. We have thus been in a unique position to observe, to experience, to learn numerous things from this tiny virus that has had such a massive impact. We have learned about that health is wealth, and that has taught us that the only thing permanent in life is not how many clothes or how many cars you have, but how good your health is. Because without health, we are left with nothing. Particularly, what many youngsters don't seem to realize is that health is not dependent on weight loss achieved through crash dieting or six packs achieved by taking steroids. Health is a lifestyle change that has to be developed over years and maintained continuously, consistently, not after we have developed diabetes or hypertension, but from a very young age. So again, this COVID pandemic has taught us importance of public health system, particularly so many public health issues are ignored in our country, from anemia, from preventable cancer, from violence against women. So many aspects are there, from adolescent health, preventable adolescent health problems. So many public health issues are there. So with this corona pandemic, we learned importance of public health system, public health uh, GDP to be allotted for public health and health infrastructure. We also learned importance of awareness, mass education, role of media, hygiene, and we were the witness of improving in environment during the lockdown. So it's we can say a good wake up call to all of us humans to see the impact we have done on the environment. We have also seen the economic slowdown. We are the witness of emotional health problems, psychological and mental health problems, and we have at the same time have seen the positive role of media angels in disguise. We have seen so many NGOs working, so many individuals are working, so many private organizations are working along with government to tackle this pandemic. So we have learned so many things, and at the end, vaccination, particularly, we can say it is the importance of hardcore science and research in saving and improving the quality of life has never been more apparent than this time. Within a short span, we can come out with the vaccines across the world. So many vaccines are coming out, and this is something a revolution research in medicine. So we have also seen the positive role importance of a hardcore science and vaccination. And many healthcare workers, healthcare providers are affected, but at the same time, with tribute to all of them, so must go on. And it has been a difficult year for all of us. Many have lost loved ones too soon to this relentless virus, but we have learned a new way of life and have learned that as a race, we humans are resilient enough to get through the worst of nature's disaster. And today, I wish grant success to this webinar with definitely it's a painful that we have lost many of some of our members or some of our relatives, but as we all are always telling, so must go on. So once again, I would like to congratulate Dr. Komal Chauhan for continuing academics and particularly keeping a very relevant topic, COVID dilemmas in obstetric gynec, with the first wave, with the second wave, and now with the possibility of third wave. It is very, very important to discuss COVID dilemmas in obstetric and gynec. So once again, I congratulate Dr. Komal Chauhan, Medical Disorder in Pregnancy Committee and its members. I wish grant success to this webinar. I wish safety to all of you. And thank you very much for giving me this opportunity. Thank you.
Thank you so much, sir. Thanks a lot for being here in spite of your very, very busy schedule. I can see that you are traveling, and that is a dedication and the commitment which you have shown us. And because of your dynamic work, you have been keeping us all on toes and encouraging us to do the best which we can do for our society, Foxy. Thank you so much, sir. And now I take pleasure to welcome our guest of honor, none other than Dr. Rishikesh Pai. Dr. Rishikesh Pai, as we know, he is a President-elect Foxy 2022. He's a Medical Director of Bloom IVF, Administrator of Foxy Manyata Initiative, Director of Corporate Affairs IFFS International Federation of Fertility Society, Adjunct Assistant Professor at Eastern Virginia Medical School, USA, a postgraduate teacher in gynecology at DNB, a visiting professor in obstetrics and gynecology, Manipal University, India, with special interest in infertility, endoscopy, IVF, ICSI, egg freezing, and genetics. We all know he's so famous for all the infertility work which sir has done all over India and globally also. He has achieved so many awards and awarded with the esteemed fellowship of RCOG, London, UK, and has been also in the Foxy office as a Secretary General and also past president of ISAR, IAG, MOGS. His CV runs into a lot of pages and he has got almost 45 plus awards to his credit. And we are very proud to have Dr. Rishikesh Pai with us as a guest of honor. Welcome, sir. And I would like you to address all the viewers who have joined today.
Thank you, Komal. Thanks for calling me. Actually, Alpesh Gandhi, our president, is there. And, I was just telling someone that the amount of work that he has done in this year, you can actually divide it into 3 times. So, like, if I have to do work, I just have to do 1/3 of the work that he has put in this year. And I still will have enough work on my hand. So, his work output has been phenomenal. And very innovative also. It was very innovative. A lot of things that he has done. I'm sure Shanta and I will continue it in the future as well, because Foxy is all about continuity and consolidation, and some kind of innovation is also necessary. So I see a lot of my friends in the gallery, like you're, of course, the dynamic chairman of the committee, and then we have got senior people here. I think I can see a lot of them. We have got Ranjana Madam, who is again a dynamic person. And then we have our Aparna from Delhi, Dr. Achla is there, Dr. Ramni Devi, Archana Verma, who is going to be the next incoming vice president. And then Dr. Lakshmi is there, Dr. Bhaskar, Dr. Parikshit Tang, our dynamic, and some of the younger people. I think Anand is probably Deepak's son, maybe. I'm just assuming. I am not, but probably he is.
Thank you, sir.
Yeah. So, and Dr. Ajit is there, and so there are a lot of people who are all very active. Foxy is like a one large family, and what Alpesh has already summarized about COVID. So, whatever I had to say, he has already said it. So, I don't think I'll repeat what he has to say. Only thing is that this is a dynamic, ongoing pandemic. Every day when we get up, it's like a new day, a new dawn for every one of us. Every day is a bonus for us. So, life has really changed. Yeah, as he rightly said, every moment is very precious and we must savor the moment and live for the present as well. We don't know what will happen in the future, but I'm sure the future is good and bright for all of us. This is like a once in a lifetime moment for us, all of us. This probably has never happened before. And I was telling someone the other day that the most crucial, important time of our life is, let's say, 55 to 70, when you're really peaking in your life. And suddenly, our generation is suddenly faced with this kind of once in a lifetime moment. And so, it is very important to face the challenge and make the best out of this once in a lifetime moment. And we being it from the human race to come out at top. So, vaccine has been a fantastic breakthrough, and I know that many more vaccines will be innovated, and our country is a very resilient country. A lot of vaccines will be produced. Once we get our act together, and I'm thinking that in Foxy we got our act together as soon as Alpesh took over. But the larger countries like a large sleeping giant. So by the time the giant wakes up and it starts moving the wheels, but once it gets it again together, I'm very confident that next year we'll have no dearth, I'm sure, because every year the vaccine is going to be produced every year. So we'll need 2 billion doses every year because the strains are going to change every year, just like influenza. And I'm sure that we'll be geared for that change. So anyway, I don't want to eat up into the precious time. And I'm looking forward to listening to all of you. After a long marathon yesterday night, I was seeing Family Man's 9 parts I saw in a long marathon. And, I was also very conflicted because, people around us, Sri Lanka, our Tamil, so many issues are there. There is nothing hard and fast in life. There's nothing black and white. Everything is anyway gray. So thank you very much for calling me again for this lovely gathering. And I hope that you have a fantastic academic meeting now. Thank you.
Thank you so much.
Dr. Komal, congratulations for a large gathering. More than nearly 2,500 doctors have already joined this webinar. Congratulations on Sunday evening, so much big gathering. It's really a credit.
Thank you so much,
sir. Yeah, Komal, only 2 things I forgot to missed out is that you're better off. I don't know which to call the better off, you or your husband.
So, I think that was a good
one. Has also helped you in your performance and also. I must also congratulate and acknowledge Subbu and his team for doing a great 1.5 years and contributing to the Foxy's academic activities. Thank you.
Thank you so much, Alpesh sir and Dr. Pai sir. Really, it was a great honor that both of you have graced the occasion with your esteemed presence, and that shows our viewers also who have joined in large numbers today for the COVID dilemmas, because this is the in topic. And before we go ahead, I would really like to appreciate the support which we get from the team Science Integra and the Alembic, the partners who have been also working very hard to bring us all on this digital platform. And Dr. Parikshit Tank, the joint treasurer of Foxy, was also instrumental in making of this webinar. So with that note, let's start our scientific program, and I welcome all the 3 speakers, Dr. Ramni Madam, Bhaskar Pal and Parikshit Tank. And I introduce the chairpersons for today's, the chairpersons, Dr. Can I have the slides? Dr. Archana Verma, Dr. Anjana Khanna, Dr. Archana Verma. Dr. Archana Verma, we all know she is the public awareness, the face of public awareness, as she has really written passionate about creating awareness on women's health, special interest in infertility. And she is now the VP elect of Foxy. Earlier, as a chairperson of Public Awareness Committee, she has done wonderful work, and she has also been an executive member of UPSAR UP then Joint Secretary of UP ISAR, and Organizing Secretary of Mid-Term UP and she has a special credit as an India Book of Award winner and Presidential Best Committee Appreciation Award. So welcome, Dr. Archana Verma. Yeah, can I have the slide of Dr. Ranjana Khanna, madam? Dr. Ranjana Khanna, as we know, she's a senior director, consultant and director of Ranjana Hospital, Prayagraj, National Vice President, Foxy 2017, founder president of Prayagraj chapter of ISOPAP, ICOG Governing Council member, and she has also adorned so many hats to a credit that is president of AOGS, honorary secretary, and has organized several conferences. The most talked about is the BOH Triology and the Savama conference. Welcome, Dr. Anjana Khanna. And we have joining them the young upcoming gynecologist from the city of Gujarat, Dr. Anand Bagade, who is a member of my Medical Disorders and Pregnancy Committee. His special interest is in minimally access surgery and hysteroscopy, and is presently working as a consultant OBGYN laparoscopic surgeon at Bagade Maternity and Nursing Home. He is also the treasurer of Jamnagar Obstetrics and Gynec Society. So over to you, all the chairpersons, to welcome our speakers. Dr. Ramani Madam will be speaking first. So let's begin all our lectures and talks. Thank you so much. Over to you, Dr. All the chairpersons.
Should I introduce Dr. Ramani first?
Yes, madam.
Yes, madam.
Thank you very much, Dr. Komal, for giving me the opportunity in this COVID times and talking on the COVID, and to introduce the most famous Dr. Ramani Devi. And we all know that she is a so much dedicated person, and we all know how personal and how being human she is, apart from a great academician. And she is a national vice president at present Foxy or 2020, and international advisory board member of Fertility Society of Bangladesh, and ICOG Governing Council member and Managing Director, Ramakrishna Medical Center, LLP and Janani Fertility Center. And she is she was a chairperson endometriosis committee of the Foxy, where in the 2016 she rocked the nation and Foxy with her work, and when she was endometriosis committee, and she's a member of consensus for endometriosis in Asia Pacific region, and investigator in POISE trial published in Lancet, and editor of Foxy GCPR and peer reviewer. And she has many awards and accolades to her name, and there are Woman of the Year award by Bharati Dasan University, and Woman Achiever.
You can just, that's more than enough.
One Best Woman Doctor Award by Tamil Nadu State, and Best IMA National Secretary Award also. And welcome, Dr. Ramani, and please do the favor. And now we are all ready to listen to you.
Thank you, Dr. Archana, for your kind words. Good evening. I'll just start. Good evening, Dr. President Alpesh Gandhi and Dr. Rishikesh Pai, and all the chairpersons, and Dr. Komal Chavan, who is the chairperson of Foxy, for this wonderful program. And she has been chasing me almost 3 times. She wanted to change it, and she wants me to give this talk. But anyway, I'm a bit worried because the first time I heard about COVID and infertility was from our great speaker, Dr. Rishikesh Pai. But then, over a period of 1.5 years, as a IVF consultant, we too have slowly learned how we should manipulate our cases and how to go about for a safe practice. So this was saying from Mohammed Patalla. The different needs in reproductive health are simultaneous and consecutive related needs. People cannot be healthy if they have one element of reproductive health package but miss the others. So now let us see how many articles are published regarding COVID and infertility. See, before this 2020, actually we never had, we didn't even know about this COVID disease, though we had some knowledge about the SARS-CoV-1 and the MERS disease, MERS viral infection. But in the year 2020, there were around 112 publications, and 21 till date it is around 94. So even before COVID could be announced as a pandemic in 2000, there was an article about COVID and infertility, who states that 1 in 4 couples in the developing nations are affected by infertility. 9% of couples all around the world will experience infertility during their lifetime. Our statistician, that is the ISAR, states there are 22 to 23 million infertile couples in India alone. Worldwide, it may be 60 to 80 million, but I'm sure it is only a tip of an iceberg, because we are likely to have even beyond that. Total fertility rate has declined from 3.9 in 1990s to 2.3 in 2019. At present, the estimated number of IVF cycles per year worldwide is around 150,000 or even beyond. It is expected to reach 25,000 by the end of 2020, but we are not able to achieve this because of this COVID situation. So what is the impact of COVID upon infertility? This crisis definitely affects the entire world, and more so the infertile couple, and it will have a negative impact upon the mental health of everyone. As aging occurs, reproductive capacity of the couple goes down. So we do not know what is the impact of COVID upon the reproductive capacity of those particular individuals. Infertility threatens the stability of individual, family, marriage, society, which will be more threatening in crisis situations. ART is a common treatment of choice for many infertile couples. Let us see how it has been altered now. See, prior experiences, what we got from the other viral pandemics, like rather I would say, put it as an epidemic, like severe acute respiratory distress syndrome, SARS-CoV-1, that was supposed to cause severe arthritis among the men, leading to germ cell destruction. Then the reports indicate decreased sperm concentration and motility for around 72 to 90 days following COVID infection, COVID-19. Gonadotropin-dependent expression of ACE2 was found in human ovaries, but it was unclear whether SARS-CoV-2 adversely affects the female gametogenesis also. So this was an article published in the year June 2020. Now, we have more clear-cut ideas. This was taken from an andrology journal, where it says COVID-19 will attack any type of the body cells which are expressing ACE2 receptors, including human spermatozoa. The reproductive consequences of viral attack on those systems in terms of fertility and risk of sexual transmission, we do not know what is the answer. However, we should be alive to the possibility that there may be reproductive consequences of COVID-19 infection in young males that go beyond their capacity to survive a viral attack. So this is a pictorial representation where SARS-CoV-2 virus can attack the ACE2 inhibitors, and then it is getting activated by the TMPRSS2 receptors, and then it infects the cells. Inflammation is the second phase, which is very dangerous, and it causes due to infection, it can lead to arthritis and affect the Leydig cells and the suppression of testosterone. As well, once when the a person is known to be suffering from COVID, there is a lot of psychological stress, and again during the role of antiviral drugs, it is now clear that only in the viral replication phase, all these antiviral drugs are effective. But once when the patient crosses this and reaches the inflammatory stage, where there is chances of cytokine storm or even a milder form of it, and there is increased oxidative stress, which can have a definite impact upon the spermatozoa and affects the DNA fragmentation. Again, This infection can affect the testes as such, involve the Sertoli cells, causing disrupted spermatogenesis and sperm abnormalities, which may be persistent for years following the infection. So then this was another article that was published in August 14, 2020 from Men's Health, World Journal of Men's Health, which says, the recent literature provides evidence that male gonads may be potentially vulnerable to a SARS-CoV-2 infection, recommending caution to the pregnant women and the couples planning natural pregnancy or ART. Again, this was an article in epidemiology protocol and how the COVID has got an impact upon the female fertility. That was a systematic review with the meta-analysis that was published very recently in February 2021. This novel coronavirus invades the target cell binding to ACE2, which is expressed ovaries, uterus, vagina, and the placenta. Significantly, it is said to interrupt the female fertility through regulating ACE2 receptors. ACE2, angiotensin 2, and angiotensin could regulate follicular development, ovulation, regulate corpus luteum angiogenesis and degeneration, and affect the endometrial tissue growth. So, starting from the follicular development up to the implantation, all the process of fertility are being affected. Again, it is highly expressed in ovaries. Therefore, ovarian reserve function should be the primary observation indicator for the impact of COVID-19 on female infertility. See, if it is going to get attached to the ovaries and have a detrimental effect, we should identify what is the aftermath of COVID infection, whether the woman is likely to go in for a lowered AMH level. So not only that, the biological clock is striking. So if we want to delay the onset of fertility treatment, maybe at one stage, the patient may not have enough of eggs. So the impact of female aging has a dramatic impact upon the success of the ART. And again, the ART calculator, a clinical predictive model, is used to estimate the number of mature metaphase 2 oocytes needed to obtain at least one euploid embryo in couples undergoing ART. Indicates that 19 oocytes are needed for women aged 38 and 39 and 40 years respectively. So as aging advances, we need more number of oocytes to get a single euploid embryo. By contrast, only 5 and 6 of the oocytes are required for patients aged 33 and 34 to have an euploid embryo. See, again, before any consultation for COVID-19 infection are suspected, that we need to have a PCR tested for all these patients who are planned for IVF or ART. So in Poseidon 3 group, there should be ovarian stimulation and ART for oocyte and embryo cryopreservation. Maybe multiple stimulations and dual stimulation may be needed. Again, for Poseidon group 2, ovarian stimulation and ART for oocyte embryo freezing. And group 4 also, either we can go in for embryo freezing or fresh transfer or without PGET as it is needed. Again, fertility preservation in oncological cases as well as systemic autoimmune disorders where there is when the patient is in a period of cyclical remission, or infertile males who are undergoing any other treatment aimed at improving the sperm quality, because once if they get infected with the COVID or aging goes on, the fertility potential of the male also drops down. Again, I will add up here, along with oncology, the endometriosis patient should also be advised fertility preservation. We should not try to delay in all these situations. So the plans, how to plan to restart these ART services, I will discuss in detail in the next few slides. So first thing, what is the impact of lockdown upon fertility? Regarding the coital frequency, initially WHO came out with a statement that during the time of this COVID situation, we are going to have more than 2 million extra births. But if you look into the actual, I don't know about the other situations, but in Tiruchi district, they have found out that the number of deliveries have come down during the past 1 year. So it could be a small focus, but I think it can very well be replicated in the other areas also. Probably when in the initial phase of lockdown, when the couples had enough time, the coital frequency could have been more, but later, then because of the boredom and the financial strains, and they have to look after the children and bear, they have to go for a heavier work to earn their this financial strains to be overcome, and all those things. And again, sitting at home, lack of exercise, proper exercise, weight gain could again lead to anovulation. And again, domestic violence was found to be of a higher incidence during this lockdown period, and inability to meet the doctors, difficulty, even though if they had a telemedicine facilities, there were problems in procuring the medications, and fear of contracting COVID in pregnancy, self and family members. There was I was discussing with one of my friends who was telling that a parent of a girl who got recently married, she came and asked the doctor whether this after the marriage, whether the couple can have normal sexual activity because of the risk of COVID upon the self and the couple, as well as for the newborns. So we still do not know how we should answer. There are certain difficult situations how we should manage these conditions. Now let us come to the ESHRE statement. On 11th of March, WHO announced it as COVID-19 as a global pandemic. ESHRE launched even before the 27th of February 2020, the first statement advising precautionary approach and recommending avoiding ART pregnancies in patients who are COVID positive. And a more elaborated statement was published in the year April 2020, not to start new ART for the following reason, mainly to avoid complications arising from ART and ART related pregnancy during COVID situation. Again, still we are unknown risk of the vertical transmission from mother to child, though initial articles were stating that there were no risk of vertical transmission. It is only the horizontal transmission, the contact of the positive mother with the child, that was leading to newborns becoming positive. But now of late, there are recent evidences to say that it can be transmitted vertically, because placenta is also found to have the receptors. Again, this statement also excluded an exception for urgent fertility preservation. So cryopreservation of gametes, embryos, germinal tissue still be considered being an emergency procedure.
Last 2 minutes left.
Yeah. Oh. So again, so this was how it has to be managed. About 4 to 7 weeks, they have almost stopped the ART work in many of the places. This was the pictorial representation, stopped in March 1st, and they started with a full bang in 30th May. And again, so these are the procedures in various countries where they stopped and then they started. And now the ESHRE is guiding that always postpone it and restart after everything settles down, or at least it plateaus. So WHO has recognized this as an infertility as a disease, and it is recommending, and there are so many queries regarding the fertility treatment. ASRM also follows the same guidelines, and British Fertility Federation Fertility Society also gives the same 5 key principles to postpone. And then these reasons why we need to take care of ourselves, the support group, the unit, as well as the patients. And the social problems are there to delay ART, and the supply chains during this COVID period to get the all these medias and so many other things, and the patient to travel and the embryologist to travel, all these things are there. So when to kickstart after COVID? Probably we need to discuss with the patient, staff, and the patient triage should be there, and the center should be adapted, and treatment planning should be there. So need to have an agreement and consent when you start the treatment, and the ART triage questionnaire should be asked. It should be there for the staff. The staff can negative points, they can start working. If they are suspicious, test for COVID, and then if they are negative, they can start. Otherwise, they need quarantine. The same procedure is applicable to the patients also. And the advice is they should use advice to the patients as well as for the staff, where they need to have the full protection, use of PPE, proper disposal of the waste, everything should be there. And then each team should be into mini groups, so that they can, even if one team falls sick, the continuity of the work may not be affected, and they need to have a other team. So the treatment cycle, with each treatment cycle, it should start from ovarian stimulation. Before that, RT-PCR should be done, and then again before the time of pickup, and then if you are going to transfer, probably that also we need to have a careful watch. So the oocyte retrieval, do you want to, when you start the cycle and in between, if the patient becomes positive, do you want to continue the treatment or not? It is ideal is to stop, but this is incurring to more expenses. But there are certain incidences that we need to continue that. That is when you have the patients are at a high risk of developing ovarian hyperstimulation, or when you need to have the fertility preservation, you have to go ahead, but always have a watch for the over the patient the next following week, and always try to store all the cryopreserved embryos and oocytes or sperms in a different can, separate from that has been used, and limit always the embryo transfers should be ideally stopped. And this is the exact pictorial representation of how you should go about with the protocols of the lab. And mental stress for the couple is going to be there, because they may not have the transfers, and again the finance involved and repeated testing. So we need to go counsel them for online counseling is needed, support group, social networks, peer supports, all those things have to be there. In general, try to reduce the stress, ask them to keep away from the social media. Then coming to the COVID vaccination, the need is definitely the patient who is planning to become pregnant or planning for ART, it is better they take the COVID vaccine, then they come for ART. So this is according to the guidelines from the ART, guidelines from ESHRE, which says that men and women should get vaccinated before attempting conception, but still we do not know how long to postpone once when they get the vaccination. I think my subsequent speaker will discuss about it. So always better to get a vaccination, as all the learned societies who ACOG, Society of Maternal-Fetal Medicine, everybody is insisting that they should be vaccinated, but they should be deferred vaccination when they are planning 3 days prior or 3 days after that, because we do not know if at all there are adverse effects. We do not know whether it is because of vaccine or not. And the side effects, I think this will be explained later. So this is finally a possible post-pandemic fertility trajectories according to the regional income is high income countries, the fertility may be decreased because of work-life balance and then economic losses, but low income group fertility may be improved because of the access to contraception is not there. And in the middle income group, it can be either way. It can be either increased or decreased. So we have overcome the pandemic, what our yesteryears, what our elders saw, that was 1918 influenza pandemic, which killed more than 50 million people. We have overcome that. I hope, I am sure that we will overcome the COVID pandemic also, and ultimately we will have the world that is free from COVID, and let us survive. And the world is only at present temporarily closed. So thanks for the opportunity given.
Thank you, Dr. Ramani. It was indeed a very wonderful presentation by you as usual. And we all know that infertility means so much of frustration and so much of heartaches, and for the family, for the patient also especially. And we need to tell them that how they are going to have this, and all this is extremely stressful condition, and the management, you very well enumerated each and everything, especially the COVID vaccine and the ART and the management. And majority of the people, they are in this question, how much time they should wait, because there's a family load. They're almost a sort of a domestic violence kind of a thing of with them also, because they are doing nothing, and the load is on the female only, whether to hell with the DNA and whatever is going on at the sperm level, but all the thing is on the shoulders of a female. And so they are really very, very worried, and they want to know what is should be the gap between vaccination and ART. This is a very common question, and you have tackled it very nicely, I think. And if you want to say again 2 or 3 words, you can say that, and then I think you have enumerated very nicely.
Thank you, Archana.
And madam, one thing, if the patient comes to know that after she has taken antibiotics and steroids during her treatment when she was there, there's one question in the chat box. So I don't, you think that we should advise termination of pregnancy, or we should say that this is something going to be normal, we cannot comment, and no, especially no medical termination?
See, I think in the panel it will be definitely discussed, but as on that, there is no need for medical termination of pregnancy when the patient turns positive in the first trimester. Still, we do not know what is going to be the impact. Though initial phase, they were telling that there was higher incidence of miscarriage, but we now know that it is not statistically, the increase in the incidence of miscarriage is not statistically significant.
Yes, very definitely, because the MTP rules remains the same.
Yes.
Can I say one thing? A very beautiful lecture, but I would like to say that I was on the draft committee for the guidelines on ART that has been done by the ICMR and released on 24th of December. So all of you who are doing infertility practice has to look at the draft guidelines, which are already out, and a special consent has also been created for doing the procedure. Before that, you have to sign that consent form. So I would like to request, because I think unfortunately we have not been able to communicate this existence of this draft guideline to the general gynecologists at large.
Over to
okay, I think we'll start with the second session.
Yes,
so can I have the CV of Dr. Bhaskar?
For the 1 second was measured. Thank you, Dr. Pai sir, and welcome, Dr. Bhaskar sir.
At the outset, I would like to thank Dr. Komal Chauhan, and of course, it's wonderful to have the presence of Dr. Alpesh and Dr. Rishikesh. So thanks for gracing the occasion. Now it is my great pleasure to introduce my co-VP, Dr. Bhaskar Pal. We had some good times together, and Bhaskar, seeing you having that, I'm sure it was black coffee that you were taking. So, because you got me addicted to that too. And Dr. Bhaskar Pal, of course, he was Vice President Foxy in 2017. And he's a senior consultant gynecologist of Apollo Hospital, Kolkata. He's Chair AICC RCOG, Vice President IAGE, and now he's Foxy representative to SAFOG. He's Chair Organizing Committee AICOG 2023 Kolkata, Vice, of course, that I've said, and is Clinical Examiner of MRCOG. And welcome, Bhaskar, to give your talk on COVID and pregnancy.
Thank you, Dr. Ranjana, for the kind introduction. Yes, it was a pleasure when we were co-vice presidents with Dr. Rishma Pai.
Yes.
And we had a fantastic year there.
Yeah.
It's great to be here. Thank you, Dr. Kamal Chauhan and the Medical Disorders Committee of Foxy for inviting me to give this talk. It's a very significant day because monsoon has just arrived. I can see out of the window in the last 1 hour, monsoon has arrived in Calcutta. We were expecting for the last 3 days. And I guess while we review our inability to meet every weekend, as Foxians, we used to do almost at least 3 weekends out of 4. I think these Sunday evenings bring back the memories that at least virtually we can see. I can see Dr. Archana, Dr. Lakshmi, Rishikesh, Parikshit, and Aparna, and so many other people. And even an hour back, Dr. Achila Batra and myself were on a different program. I have, my Kamal gave me the topic of antenatal care in COVID, and I have divided this talk into two parts. One part would be how to go about providing antenatal care during the pandemic. And secondly, in brief, that what are the particular points in a pregnant woman when she gets infected with COVID. I will not get into the issue of vaccination at all because leave it to Parikshit, and would leave the finer details to the panel, which will be moderated by Komal. Now, what are the problems with antenatal care during the pandemic? Number one, patients are scared to come into the hospital because they are worried about getting COVID infections from the hospital, especially now when almost every hospital has to take COVID patients. Secondly, the healthcare workers are worried that they might get COVID from pre-symptomatic patients. This was more of a worry in the first wave than in the second, say because healthcare workers mostly have got vaccinated. Local lockdowns prevent women from traveling, and also they have a higher threshold of going to the hospital. So even if they have some pain, some decrease in fetal movements, they would rather wait and see what happens. A bigger problem has been a redeployment of healthcare workers. We had 3 weeks back, we had our registrars taken away to the COVID ward, our sisters taken away to the COVID ward, and we were functioning with skeleton staff, which does affect services. It is important to understand that there are effects of pandemic and isolation on the mental health of everybody, but especially pregnant women. It gives rise to increase in domestic violence. Irrespective of however much we say, whatever we do, India is still a patriarchal, male-dominated society, and women take the brunt of everything. We know at the present moment that there is an increase in stillbirth in COVID times, and not due to COVID, but due to lack of antenatal care, either women not seeking antenatal care or because we are unable to provide antenatal care. Now, to go briefly about SARS-CoV-2 is a strain of coronavirus which causes COVID-19. It's a human-to-human transmission, respiratory droplets or secretions. There are worries about feces and fomites, but at the present moment, we don't think that's significant. Main worry is with respiratory droplets and secretions. It is essentially from close contact with an infected person. Asymptomatic or mildly symptomatic patients remain infective for at the most 7 to 10 days. So when an asymptomatic or a mildly symptomatic patient goes past 10 days from the initial symptoms or 10 days past a positive test, they are not infected. We look at the CT value. The CT value tells us more about the viral load and the ability of the patient to transmit the infection, but it does not correlate with disease severity. There are dilemmas and diverse opinions about what kind of aerosol generation can take place when a patient coughs and sneezes. But we need to be worried about aerosol generating procedures, which means using a suction, doing an intubation, etc. But what we've learned in the last 1 year and 3 months, that mask, hand hygiene, and social distancing seem to be the most important interventions to prevent infection. Now, what we've learned in the first wave as well as the second is that pregnant women are not more susceptible than non-pregnant women, which means the chances of a pregnant woman catching COVID-19 is the same as a non-pregnant woman. There are slight differences between COVID-1 and COVID 2.0. In COVID-1, it was a more person-to-person transmission, whereas in COVID-2, cluster infections have been very significant, which means that this the mutated viruses of the second wave are more, they have a higher transmissibility compared to the original virus, and so which means in events they have managed to transmit to clusters. Is the severity of COVID in pregnant same as non-pregnant? In first wave in India, what the data we had, definitely so. They had same severity as in non-pregnant, which means that approximately 85% will have an asymptomatic or mild infection. About 10% will have a moderate infection which might need hospitalization. About 5% will have a severe infection. However, the WHO and US data seem to indicate from the first wave that more ITU admissions were in pregnant women compared to non-pregnant. And this was especially coming in from Italy and New York. Fever and cough are significant symptoms symptoms in COVID in pregnancy. What we need to remember in COVID 2.0, we can see more pregnant women having a severe disease requiring admissions and oxygen therapy and steroids and anticoagulants. And most of these women are in their second trimester or early third trimester. This is from the first wave, that less frequent symptoms were dyspnea, myalgia, loss of sense of taste, and diarrhea, and each were present in more than 10% of women. Again, another difference between COVID-1 and COVID-2. In COVID-1, we said if you lose your sense of taste and smell, you're likely to have a mild disease. Whereas in COVID 2.0, a lot of women and men with a loss of sense and taste and smell are still getting a severe disease. Fever and myalgia are less common in pregnant than non-pregnant women, and the mortality is lower in general in reproductive age women, and 60% less likelihood of ITU admissions in women compared to age-matched males, and possibly there is a protective effect of estrogen. Now, this is from the first wave and part of second wave. This is published from the UK OSS study, 427 pregnant women. The most women who were hospitalized were in the third trimester. 9% required level 3 critical care, less than 1% required ECMO. And if we look around at our COVID 2.0 data, more or less it would look similar. Only difference is that patients' hospitalization in late second trimester and early third trimester has been the most. The French data said the risk of admission in second half of pregnancy is 5 times compared to first half, and that seemed to be worldwide. What we are seeing in the second phase also is that more disease happening in younger patients. That one reason may be that the younger patients were not vaccinated. Severe disease and mortality we are seeing in young patients. The other very important thing in the first wave, we were saying that we should get people with high risk factors tested around day 7 because the complications tend to happen between day 10 and day 12. In the second wave, we are seeing complications developing within 4 to 7 days. And so it's a conundrum as when we want to test them for complications. More pregnant women are getting moderate severe disease in the second and third trimester. I have already said that more cluster infections and more contagious. So how should we continue our antenatal services, and what should our pregnant women do? All pregnant women, regardless of gestation, should observe the social distancing and self-isolation guidance, especially those above 28 weeks, given the fact that we know in third trimester, it tends to be more severe. They should minimize all non-essential contact with other family members. And what is reassuring is that if the women are infected with COVID-19, they're still more likely to have no symptoms and a mild illness from which they'll make a full recovery. But alertness is important so that they need to monitor themselves, and if they develop more severe symptoms or their recovery is delayed, which means a persistent fever or a fall in saturation or breathlessness, they should consult their doctor immediately. So what can we do about the antenatal care? We can reduce or postpone the visits or increase the interval between antenatal visits and routine scans. What is most important, and that is very important in terms of protecting healthcare workers, we need to shorten the duration of the antenatal visit. We should try and limit our antenatal appointments or the duration of the patient contact time to definitely less than 15 minutes, if possible to around 5 minutes. We need to limit visitors while in clinic or in the hospital. We need to individualize plans for women who require frequent reviews because of high-risk situations. And we need to continue to provide antenatal care to high-risk women. And also it is important that where possible, we offer them a one-stop clinic appointment, which means they have a consultation, they have an ultrasound, they can give their blood tests and go away. WHO recommends 8 visits, RCOG a minimum of 6 face-to-face visits, antenatal contacts in total. ICMR recommends minimum 4 visits, and we find that quite logical, that the visits happen at 12, 20, 28, and 36 unless they meet self-isolation criteria. And out of this, during this 4, they have their blood test, and during this 4, they have 3 ultrasounds. The results can be communicated over the phone. Any woman who has a routine appointment delayed for more than 3 weeks must be contacted, and need for the appointment is greater than the risk of being exposed to COVID-19. Remote consultations have taken over hugely, and there are still some conventional seniors who don't believe in remote consultations, but especially for follow-up women, We find remote consultations to be very useful. They can be done over video or teleconsultations. And these should be appointments where tests are not required. And this should be an adjunct to the physical appointments, which must happen at 12, 20, 28, and 36 weeks. Here we can review the results of the test, order the blood test, schedule physical appointments, and patients can check their blood pressure and weight at home. If necessary for gestational diabetes, they can do their blood sugars on a capillary blood glucose monitoring system. They should do a fetal movement count if it is required. They should stay well hydrated and mobile at home to avoid the risk of venous thromboembolism. And it is important to talk about their mental health, mental well-being. If there are any concern, we should advise them of physical attendance. And what are the do's and don'ts for the obstetric healthcare worker? If a woman meets the criteria for COVID-19 testing, she must be tested. If somebody is symptomatic and is not tested, and it is not urgent or an emergency to see her, we can delay her physical appointments by 7 to 10 days. Because as we said, that for mildly symptomatic women, they're not infective beyond 10 days. But do not delay obstetric management in order to test for COVID-19, especially in emergencies. Elective procedures like routine induction of labor or routine growth scans and routine investigations should be reduced to minimum. If ultrasound equipment is used, it should be decontaminated after use. Now, this is the INSWA guidelines about how we should go with scans in women with in the COVID pandemic. Does this woman need to be scanned? And we can divide them into 3 groups: scan without delay, and there we would do that like obstetric emergency, ectopic, antepartum hemorrhage, or it is needed but it can be delayed, like growth dating scans and growth scans and fetal medicine procedures, or can be avoided completely. And which are these? These are transvaginal early dating scan when there is no problem, or an ultrasound for reassurance. The dating can be done during the early morphology scan, which is scheduled between 11 to 14 weeks. The ideal time possibly would be around 12 to 13 weeks. The second trimester anomaly scan should be given a priority over first trimester scan. The routine growth and Doppler scans should be postponed from 32 to 34 to 36 weeks. And decision-making growth and Doppler scans between 28 to 41 weeks should be considered on priority when the woman has high-risk factors. So how would an antenatal care schedule look like? Patient's physical appointments are 11 to 14 weeks. Patient comes in, has a screening for Down syndrome, dating scan. At the same time, has the booking bloods. They come back at 19 to 20 weeks, have their anomaly scan. At 28 weeks, they come for a physical check, screening for gestational diabetes and repeat bloods that needed. At 36 weeks, they have a growth scan, and then a delivery plan is made. And in between, we can have virtual appointments at 16, 24, 32, and 38 weeks to supplement the physical appointments. How do we protect ourselves in the OPD? If we wear an N95 and a surgical mask, that is most important. Goggles and face shield, many of us have now abandoned. The patients and relatives sit 3 to 4 feet away from the doctor. If we are examining patients, if we are touching patients, we need to have gloves on and preferably a wear-on. Paper roll on the top of the bed sheets, which should be changed after every patient. Hand sanitization before and after patient interaction. And in addition, hand wash with soap after each patient examination. The surfaces should be cleaned at regular intervals. And I will not go into this appropriate PPE anymore. We have realized in the last 1 year, 3 months, that your N95 mask is very important. But what is important that in view of false negative tests of COVID RT-PCR and HRCT chest, all patients are presumed to be positive, like we used to do with HIV earlier, like universal precautions. Hence, appropriate protection, depending on where you are, you should take contact protection or droplet protection or aerosol protection. What we spoke about in the OPD is essentially contact and droplet protection, and hand washing and social distancing, even among colleagues, is very important. Now, if a woman has symptoms, when should you test her for COVID? Earlier, we were saying that we should test them ideally around day 4 to day 6 of symptoms, because before that they might test false negative. Given the fact that in this wave, the patients are getting severe disease by around day 5, day 6, and in many places, especially away from metros, there is a turnaround time of doing an RT-PCR. You may do the test as early as on day 2, even on day 3. There are, in the new wave, especially with the Delta variant, you know that there are RT-PCR has a problem picking up tests, and Sometimes you need to do multiple tests to get a positive RT-PCR, and you need to keep that in mind. If you have symptoms suggestive of COVID with a negative RT-PCR, please don't discount that as a non-COVID patient. Rapid tests are there in the form of CBNAT, but CBNAT is again in the second wave has not been that useful. Rapid antigen test is good in the sense that if it is positive, you do not need to repeat an RT-PCR. If it is negative, you still need to do an RT-PCR. In the non-pregnant women, HRCT chest sometimes is a useful adjunct. But as I said, if high index of suspicion, you need to retest. If a patient is symptomatic, especially has fever on day 5, must test without delay. As we said that we screened for potential complications on day 7 to 10, especially if the patient had risk factors in COVID 1.0, but in COVID 2.0, we should screen for potential complications along day 4, day 5, if the patient has risk factors. Now, what has been seen in COVID times is that there is a 3-fold increase in the risk of preterm birth, and that's mostly iatrogenic. And especially when somebody gets a severe disease in the 3rd trimester, and there is a potential that the patient might worsen and may require ventilation, or a prone positioning. That is when patients have been delivered, and then the intensivists have taken over. 27% had preterm birth in the UK OSS study. 47% were iatrogenic for fetal compromise, and there was an increased fetal growth restriction seen in the SARS epidemic, but not this time. 59% had cesarean section in the UK OSS study. In one Chinese study, there's a 92% cesarean rate. In our country, also the cesarean rate is very high, and that is essentially because of logistic reasons. 20% patients had the cesarean under GA because they had either severe COVID symptoms or there was an urgency of birth. Effect of COVID-19 on fetus, there is no increase in stillbirth or neonatal death, although during the pandemic, there has been an increase in stillbirth rate, which I've spoken about earlier. We're still uncertain if there is an increased risk of miscarriage. The jury is still out of that. There is no evidence of increased FGR. About 2.5% babies tested positive in the UK OSS within 12 hours of birth. We know that vertical transmission does happen. Even day before yesterday, we had a baby tested positive 48 hours after delivery. That is when we test. But what we know for sure that the vertical transmission is rare and no ill effect on the fetus has been demonstrated. What do we do if the patient tests positive? Isolate at home with a caregiver, consult them virtually, educate them about red flags, monitor SpO2 with a pulse oximeter, and at least once in a day after a 6-minute walk. We should start vitamin D in these patients. Consider antibiotics only if they're symptomatic. To be very honest, the only 2 drugs which are of proven benefit are 2 symptomatic drugs, and they are paracetamol and antihistaminics if a patient has a mild infection. There is no evidence about any other drug. So there is no point starting the patient on any antibiotics if there is no problem. Vitamin D we are starting it as a supplement. Consider antibiotics if the patient is symptomatic to prevent a secondary infection. Steroids for 10 days are useful, but if you look at the recovery trial data, it is useful only in patients who have had a low SpO2. Consider thromboprophylaxis. In fact, if the patient has a moderate disease also or has higher risk factors, then it is better to err on the safer side and give them a thromboprophylaxis with a low molecular weight heparin. If the patient is in 3rd trimester, plan an ultrasound for fetal growth and well-being 2 weeks after she tests positive. And if she is near term, then we need to talk about planning the timing of delivery. Now, with the timing of delivery should be immediate or delayed. Now, as I said in the first wave, places like New York had showed that women were getting more severely affected than other people. So when somebody had tested positive near to term and required hospitalization, they would deliver her in the first week. Whereas in UK, very much like India, the patients were more likely to be asymptomatic or mildly symptomatic. The reason people were delivering in US early is because the patients would get worse in the second week. Whereas in India or UK, what people were doing is that we were considering delaying delivery by 7 to 10 days so that the patient gets less infective and there's less chance of the infection getting transmitted to healthcare workers or other patients. But if the patient has severe disease, we need to consider delivery. And Please remember, during the pandemic, however the urgent the cesarean section is, you still need to wear an appropriate PPE. Cesarean, although we say cesarean is only for obstetric indications, we often realize that there are logistic issues of monitoring a long labor in a COVID positive woman, and that is why cesarean section may be preferable. The patient needs to be delivered either in a dedicated COVID OT, or if you do not have a dedicated COVID OT, at the end of the operating list, and then it's sanitized. This is about neonatal transmission. In UK OSS study, 5% of the babies tested positive, 6 within 12 hours, out of which 2 were delivered vaginally and 4 by cesarean, and 6 after 12 hours. Again, 2 were delivered vaginally, 4 by CS. The rate of neonatal COVID-19 infection was no greater when the baby was born vaginally, when the baby was breastfed, or when the baby stayed with the mother after birth. So we recommend rooming in and breastfeeding if the patient is COVID positive. If a patient is getting into a moderate disease, what investigation should she have? She should have an imaging of the chest. She can have an X-ray with a abdominal shield, and if required, she can have a low radiation CT scan with an abdominal shield. We need to have a CRP, CBC, liver function test, renal function test, if required, a procalcitonin, a ferritin, and an IL-6, and a D-dimer. We all know that the D-dimer does get raised in pregnancy, but if the D-dimer might get abnormally high, that would make a decision of how long this patient should be on anticoagulant. And this should only be for high-risk women or those who have a low saturation or have a red flag. And a red flag would be when the patient has a respiratory rate of more than 30 and SpO2 of less than 95%, a fall of SpO2 by more than 4% after a 6-minute walk, a reduction in urine output or suggestive of AKI, or if she's in the hospital, an FiO2 of more than 40%. What would be the criteria for admission? A loss of or change in sense of taste or smell, either in isolation or in combination with any other symptoms of COVID-19. If there's a clinical or radiological evidence of pneumonia, if the patient has ARDS, a fever of 37.8 or more, and at least one of the following: acute persistent cough, hoarseness, nasal discharge or congestion, shortness of breath, sore throat, wheezing, or sneezing. So the take-home messages are: the pregnant woman should follow the same recommendations as non-pregnant women for avoiding exposure to COVID-19 infection, but they need to be extra careful after 28 weeks. Antenatal care through teleconferencing is key to providing quality care during the pandemic and to reduce the number of antenatal visits. Patients should be triaged based on symptom severity and obstetric emergency. There should be a multidisciplinary approach to management of suspected and confirmed cases. And healthcare workers should take adequate precautions as required, appropriate level of PPE depending on what they're doing. And we need good record keeping, and we need to maintain a pregnancy registry. Thank you very much.
Thank you, Dr. Bhaskar. I think that was a very, very comprehensive and very complete presentation, if I may say so. But I wanted to just point one thing out, that if the patient is she's approaching term and she's not COVID, but if she's a working woman, then I normally like to advise my patients that you go in isolation at around 36 weeks. And don't go out, just be in isolation so that you don't catch the infection and you can be relatively safe during your delivery procedure. And normally, of course, we treat them like any other patient, of course, unless the condition becomes very severe, then we have to weigh the pros and cons, whether we have to deliver immediately or whether the cesarean will take a toll on the patient's already failing respiratory system. So, and even if the patient's RT-PCR is negative, we can't be very complacent about it nowadays because there are a lot of false negatives coming up. So in that case, if the patient has a lot of respiratory symptoms, we can go ahead with the CT or with the chest X-ray with the lead shield, with all field precautions, because we have to be sure what we are treating. And of course, the patient has to be very patiently counseled and she has to be explained about her position. And in case of preterm labor, we can always give a course of antenatal steroids like we give. Dexamethasone would be preferred to betamethasone in these cases. So we would prefer to give a course, even though she's getting her methylprednisolone or whatever, but we can give a top-up dose of antenatal steroids for fetal lung maturity. So I think that would be
I think I want to respond on the three things. I think it's a great idea for patients to isolate from 36 weeks.
Yes.
But the term that is used in UK is also shielding. Shielding is something in a step lower than isolation, and they recommend that pregnant women should be shielding from 28 weeks.
Yeah.
Which means that they should not be unnecessarily going out, going in a crowd, going into any gathering. So one step less than isolation, but from 36 weeks we can.
I advise my patients that the working women that please go in isolation.
And we are having a fight. We employ 55,000 people in our hospital. Most of them are women, and we are getting into a problem with the hospital administration because we are advising that all women staff who are pregnant and more than 28 weeks have to be moved to no clinical contact with patients, and that's been a very big idea contention. The second point is I think we all of us have understood that when you follow the CT's curve and the CT's curve is high, anybody who's got symptoms is COVID positive. Maybe 1 in 100 will not be actually positive, will have a fever for something else. But even if it's a UTI, even if you think it's something else, patient has fever, 98 to 99% chance that they are COVID positive. And the third,
but I think the TLC, if we do a
that's right.
TLC and DLC,
you look at the neutrophil.
We'll be able to delineate whether it's a sepsis or whether it's actually COVID, because in this you are going to have.
You can go the neutrophil lymphocyte ratio. Is very
yeah.
But I think we need to be very cautious about steroids, because I can see even in our city there are physicians. See, the problem has happened is beyond the numbers have reached such a stage that only intensivists and pulmonologists cannot manage COVID. Even simple physicians who never managed acute emergencies are coming in and managing.
True.
And people are using higher doses of steroids, and those are causing enormous amount of problems. So I think
but for preterm labor, Bhaskar, for preterm labor, we can give it for 2 days.
No, that's absolutely fine. But I think patients are being started on steroids at home, even without desaturated.
No,
there are patients.
That's not correct.
Very high doses of methylprednisolone inside the hospital, and we need to be very careful about, in the care of the obstetric patient, when we involve a physician, we need to involve a physician who knows about all this.
Exactly. Yeah. So ultimately, and then plus if the patient is very serious, we have to be very careful whether she can bear that stress of cesarean. We have to explain to the relatives, basically. We have to do very good counseling as to how exactly we're going to handle and what are going to be the pros and cons. So that was a wonderful talk.
Can I say that, I feel it's a beautiful presentation. What I was thinking is that Parikshit is there already from the administrative side. You need to make a very small, very precise algorithm, just 2 pages, so that any member can access it. I know you must be already having it, but many of us are not aware where it is. So having it somewhere has no value. Accessing is very important. So suppose I want to know anything, what Bhaskar said, such a beautiful thing he said. Before that also Ramani said, and I'm sure you will say, you make a 4-page and put it on the foxy.org, which can be easily accessed. Do something where access quickly, they can open on their handle, see what is the management, and you have a uniform access and management. Don't make 10, 15, 30, 40, how many pages you people make. Just make a 2-page clarity access system.
Right.
That's all. This is my request to you.
Very good suggestions.
Yeah. Very well said, actually, Rishikesh.
Thank you, everyone. Without further ado, and before I introduce our next speaker, thank you, Dr. Komal ma'am, and our esteemed faculties, Dr. Alpesh sir, Dr. Rishikesh Pai sir, my chairpersons along with me. Thank you for having me, the Foxy Medical Disorder in Pregnancy team. And well, we all know the academics related to Dr. Parikshit sir. So please, if we have his slide, I can introduce him. Yes, Dr. Parikshit sir, he is a consultant at Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction in Mumbai. Along with it, he is also a consultant at Jupiter Hospital, Thane. He's a joint treasurer of FOXY, chairperson Safe Motherhood Committee, FOXY 2014 to 17, and a managing committee member of the Mumbai OBGY Society. He has various awards and publications under his name, a few of which are the Dr. K. Bhaskar Rao Gold Medal for first place at DNB, Dr. Kamini Rao Yuva Foxy Orator 2011 and 12. He has over 100 peer-reviewed publications in index journals, CME publications, and textbooks. He has co-authored more than 4 books in our field, and he's on the editorial board of 4 indexed journals. Sir, it is our honor to have you as a speaker here, and I would hand over the mic to you for your lecture. Thank you for having us, sir.
Thank you, Anand. Very kind words from you. And if I may be allowed to start sharing my screen now. Yes, I hope it's visible to everyone.
Yes, sir.
Yes, sir.
Yeah. Okay. So let me begin with this quote from the CEO of Gavi, that's the Global Alliance for Vaccines. And what Berkeley says is that the return on investment in global health is tremendous. And the biggest bang for the buck comes from vaccines because they are the success story of public health. They are cost effective and they represent the best investments that we can make in terms of public health in these times. So thank you, Komal. Thanks for the invitation to join today's program. And I'll be talking about the COVID vaccine in women. Disclosures, I have no financial or business interests, unfortunately, in any of the companies which make vaccines. And I don't receive any compensations for lectures on the same. At the outset, my thanks to all the office bearers who have, taken great pains to encourage this FOXY position statement on COVID vaccination for pregnant and breastfeeding women. And here I must thank Dr. Alpesh Gandhi and in particular Dr. Atul Ganatra for the support and the hard work that has gone into making this position statement.
Sir, is there any background noise around your?
No, not really.
Because we are getting a lot of sound disturbance.
As if you're in a storm.
No, I'm just sitting
There's a
at
whistling
home.
wind sound.
No. Okay, give me a second. I'll just close the window and see.
Yeah, because sir, all the other speakers have been muted.
Okay. I don't know why that's happening. The AC is quiet and the window is also closed. Is it still there?
Yes, sir.
Sir, some whistle sound is there.
It could be from the computer system.
Like a siren,
Like a siren.
No, Parikshit, it looks like you're flying into space.
Parikshit, any other device is open?
No, nothing, sir. Nothing. Should I log in from another device? Or
we
should
want
I just...
Yeah, I think you should log in quickly because we want to listen. Yours is a very important talk, like
important
other
talk
two talks as well.
Let me do it right away.
Maybe you can, in the meantime, he can...
Almost seems like a flight going to take off.
If there are any questions, maybe I
wanted to ask you and Ramani, the first wave and the second wave, there was a, second wave is more toxic kind of, in terms of mortality. Though I was talking to Niranjan Chavan the other day, he said there's not increase in mortality per se in Sion Hospital. So what is your opinion in the eastern zone in Calcutta? Have you seen higher mortality or morbidity?
Much higher mortality. Much higher mortality.
Yeah, in the north, UP and all.
In UP, there's much higher mortality. In Allahabad itself, we have lost some really young doctors.
Okay.
Such a small place, but we were having to the tune of around 3,000 positive cases per day. Now they have dropped dramatically to say around 40, 45.
Yeah, I think that. But West Zone, Komal, what is your opinion? West Zone, was there a problem?
So I feel in a city of Mumbai per se, the cases had dramatically increased. There are few cases who become COVID positive, maybe post delivery, who had.
But mortality rate wise?
Mortality wise, I'm not seeing much of a change, but definitely morbidity wise, we have really patients coming bleeding. A lot of abortions and IUFDs have increased a lot during this
Lots
time.
of missed abortions are coming up. Lots of missed abortions.
One reason for increased mortality is in the second wave, many patients did not come. In the first wave, everybody came to hospital. So we had more COVID patients and, few of them died. In second wave, only the very serious ones came to hospital. And we had, if we see the data of only COVID patients who came to hospitals in Delhi, from 4%, we had 10% of all the COVID patients, pregnant patients who came to hospital. But I think we cannot make a generalization because it is because of more serious patients coming this time. So,
and what about the All India Institute?
I think the disease was also more severe, and mortality was rather quick, and many people went immediately on ventilators. And
right, agreed. And the patients came late. That was another thing. First wave patients came immediately. Second wave they came very late. Another thing was that there was a shortage of things also.
So what is the experience of All India Institute and Bhaskar? We missed you. We were asking about what is happening in the East as far as the maternal performance is concerned.
And the maternal performance, we've lost very few mothers, but we've had much more mothers requiring admission and oxygen and steroids and anticoagulation this time. And most of them were between 20 to 30 weeks. Very strangely, we have less asymptomatic COVID this time. Just testing before section and turning positive, those were much fewer than COVID 1.0. And I don't think patients were seeking admission late. There was a huge crisis of beds, monitored beds. And that is why patients were not getting beds. And that was a bigger problem of the higher mortality in COVID 2.0. It's not because they presented dead, it's because the numbers, with the sheer numbers that even if 5% required hospitalization, there was not, even now in the city, we do not have free monitored beds. Although we have plenty of free beds around which you can admit patients who actually don't require hospitalization.
This is the problem in Delhi also, because people from all over, they keep flooding into Delhi. Like even from UP, from Allahabad and all, anybody who gets sick rushes off to Delhi or SGPGI, Lucknow. Otherwise, I think the strain is maximum on Delhi, that's why. From the north side.
Aparna, what is your call?
Sir, I would completely agree that the second wave is completely different from the first wave. The first wave, there was less morbidity, mortality. Second wave, mortality is more. And definitely COVID-associated pneumonias are definitely more. And the severe form is more. Pregnant patients going on vents, they're requiring preterm deliveries at 32 weeks. We've had to actually do cesarean sections to improve ventilation. So the refractory hypoxemias, taking decisions for deliveries at 32 weeks. So I think some of the very difficult decisions, very difficult managements in pregnancies. So this is the reason why I think actually vaccination in pregnancy took such a big, push that, if you deny vaccination, it is something that you are actually denying something very important to a pregnant woman.
And we are talking of a tangible risk of COVID complications in women versus an intangible risk of vaccination. It actually pales into insignificance.
Of course.
So I think withholding vaccination to pregnant women is absolutely.
In fact, pregnancy became a scary thing during the second wave. People got scared of.
I think our experiences in all over the country with second wave and pregnancy has been the same as the New York experience during the first wave. That more women getting into COVID pneumonia in pregnancy.
Yeah.
And I'm tending to believe that pregnant women are more susceptible to pneumonia in the COVID 2.0 than non-pregnant women.
I think Parikshit is.
We have Dr. Parikshit online. Dr. Parikshit?
Yeah, I'm just going to Is there still a sound now?
No.
No. Okay, great. Okay.
There's no sound now.
Yeah, I think I'll just start sharing again, and hopefully we should not get disturbed.
Yes, sir. Yes. Now there is no sound.
Maybe
Background.
Meenal, now you can share it. Is that possible?
Yeah. Yes, sir. Yes, I'll do that.
Thank you. Thanks. I'll just keep my video off as well, and hopefully things should progress smoothly. Yes, can we go ahead, please, Meenal? Thank you. Let's go to the third or fourth slide, please. Meenal, could you advance the slides, please?
Yes, sir. Just a second.
Yes, if we could just keep going. Thank you so much. My thanks to Dr. Pai for filling up that gap in because of the technical glitch. I don't know what happened. Thankfully, that sound has died down. So I was saying I have no disclosures, and this is the Foxy position statement that we came out with a few days back. Yes, next one, please. So, of course, we know that the general precautions of the mask, social distancing, and hand sanitization cannot be given up even if vaccine is taken by any individual. So let me put that out right up front before we move on. Next one, please. So today we have essentially two vaccines which are available in India on a large scale, and one which is just on the anvil, that's the Sputnik. So we have Covishield, which is also called the AZ vaccine or the Oxford vaccine, made by Serum Institute of India, and it's an adenovirus vector vaccine. The Covaxin is an indigenous vaccine made by Bharat Biotech, and it's a killed whole virus vaccine. Both of these are administered 0.5 ml intramuscular in the left deltoid, and the two doses, now that's the place where controversy has sprung up. Earlier, the duration between the two doses was supposed to be 4 weeks, but now it is 12 weeks. Sputnik, again an adenovirus vector vaccine, and the two doses are to be administered 21 days apart. One more version is called Sputnik Light, which is for a single dose vaccine. Next, please. Next, please. So when we look at Covishield and Sputnik, previous slide, please, Meena. As I said, these are adenovirus vector-based vaccine where the genetic material from the COVID virus is inserted into an adenovirus which is harmless. So here, no coronavirus as such is injected into the subject who is receiving the vaccination. Obviously, there cannot be a viremia, and therefore there cannot be a disease. However, this is a relatively new type of vaccine technology, and the only other vaccine which has been used for pregnant women of this variety is the Ebola virus vaccine. From 2015-16, it started being used in certain parts of Africa. Next slide. Please click. Yeah. So the Covaxin is a killed whole virus vaccine, and this is something which we have been using different types of these vaccines in pregnancy quite routinely. A prime example is the influenza vaccine, which is now a part of standard recommendations for a pregnant woman. Again, it's a non-replicating vaccine, so there can not be disease or viremia. Now, I'm stressing on this point especially because viremia and viral disease are important to have effects to the fetus when we are injecting it into a pregnant woman. So this little bit of theoretical background has to be borne in mind. Next slide. The story of COVID vaccination in India started on 16 January 2021 with frontline workers being inoculated, and then gradually we opened up to more age groups. From the 1st of May 2021, everyone above 18 years of age is eligible to take the vaccine. Click please. And because of this, the story opens up to the reproductive age group. Now, this decision about providing vaccines to pregnant and breastfeeding women will affect the lives of 50 million people over the next year. Click, please. Where do we stand? As of not 21st May, but the 6th of June, we've administered something like 23 crore doses. Click, please. So 230 million doses of vaccine have been administered in our country, which is a big deal. Globally, this means we are behind only China, whom we can't trust, and America. Click, please. But the problem lies in the fact that we are just a huge population. And therefore, even with these huge numbers, we have managed to inoculate only about 13% of our population with a single dose and only about 3 to 4% with the full vaccination. And this is where the difference lies with countries like Israel, US and the UK, where 40 to 50% of the population has been vaccinated. Next, please. So if we ask the question, why vaccinate? It's because as in the general population, vaccines work. They reduce the risk of infection. They reduce the risk of serious disease. Mortality is close to zero in fully vaccinated individuals. And yes, I agree that there are rare instances, but here we are talking about 1 in a crore, 1 in 10 lakh, those kind of figures. They will also prevent long-term sequelae. Public good is there because reduction of transmission is there. That's the only way we are not going to have more waves in this pandemic, and it will ease the burden on medical infrastructure. Click, please. So why do we want to vaccinate pregnant and breastfeeding women? Because just as vaccines work in the general population, they will work for this population too. Let's remember that pregnancy works as a comorbidity, and there are a larger risks of the severe disease and mortality. We've seen what the second wave does to mothers and babies, and there is also the added benefit of passing immunity to the baby in utero as well as to the neonate. Next, please. What evidence do we have to show that vaccines work? Well, this is a paper from April 2021 for frontline workers, and as we can see, there's a dramatic reduction in the chance of getting the disease, of getting an infection in frontline workers, even if one dose has been taken, and a greater reduction if the full dose has been taken. Next, please. All vaccines work, and this is data which is emerging from the UK, where population-based surveys have been done, which include the Pfizer as well as the Covishield data. 65% reduction in infections, even with only one dose. Both vaccines seem to offer equal protection to the general population. Next, please. ICMR also came out with the Indian data, and the risk of infection after one dose of Covishield or Covaxin is 0.02 to 0.04%. And this is really, really significant because it proves that both these vaccines are working in our population. Next, please. The same is true even for local data. I mean, if we look at Mumbai, the blue line represents the mortality in over 60-year-old people. What is the expected mortality rate is in red and what's the actual is in blue. Not all of them have been vaccinated, but as you can see, vaccination of the general population reduces the risk of death in general in an elderly population. Next, please. Vaccines work in pregnant women too, and the immune response has been studied. The same level of immunogenicity and antibody generation is there, and the passage of antibodies has been confirmed in cord blood as well as breast milk. Next, please. Here are some of the concerns that have been put forth. The main one is that there could be a transmission of the infection to the fetus or the neonate due to vaccination. Obviously, there is absolutely no rational basis for this. There is no infection which is generated in the mother itself, because there is no virus which is going to cause a disease in the mother. Let us remember this very important point before we think along these lines. The second concern is teratogenicity. Again, what I had mentioned in the basic science slides, that there is no viremia, there is no viral replication. And these mechanisms are absolutely essential for any virus to have any sort of teratogenic or fetal effects. Both the vaccines which are available in India today, Covishield and Covaxin, are absolutely non-replicating. So there is no possible mechanism for teratogenicity or fetal effects. The third concern is thromboembolism. Yes, there is a slight increase in the baseline risk in pregnancy and puerperium, which exists all the time, but it is estimated that the risk of mortality from COVID is 10 times higher than the risk from thromboembolism if somebody is vaccinated. Next slide, please. What happens to pregnancy's outcomes after vaccination? And here, this is data from the VSafe registry. Nearly 1 lakh women have been studied with the Pfizer mRNA vaccine. And what we've observed is there is no increase in any of the bad events which can happen in pregnancy, including miscarriage, stillbirths, preterm births, SGA babies or congenital anomalies or neonatal deaths. Click please. Here we must acknowledge that we don't have the same quality data on Covaxin and Covishield in terms of pregnancy and lactation, but it will emerge very soon if we start administering it. Next please. What's the current status? As of today, if you look at the MOHFW website, even now it's mentioned that pregnancy and lactating women are contraindicated from taking the vaccine, but we all are familiar with the circular which has come out from Shri Rajesh Bhushan, which says that COVID-19 vaccination is recommended for lactating women. And this was a big win as far as our community of women's healthcare providers is concerned. It's a step in the right direction. Lactating women represent about 25 million individuals in our country, and there has been a permission which has been granted for this population. We are striving that this should be extended to pregnant women as well. Next slide, please. So the real benefits of protecting mothers who are getting infected and facing serious health risks for themselves and their babies has to be weighed against the purely theoretical risks of harm which may come, and here I must stress the word may come from the vaccine. That's the choice that we are faced with today. And to my mind, the choice is very clear. It's number one. There are much greater real benefits from protecting women and their babies with the vaccine. Next, please. At present, I must emphasize that individual practitioners cannot advise vaccination to pregnant women in India until there is a change in the recommendations from the ministry and the government. And we are eagerly awaiting the inputs from the NTAGI and the NEGVAC. These are the bodies which will make the recommendations to the MOHFW. Next, please. The recommendations need to change, and I don't think there's too much of doubt about that. We need to rationally apply newly emerging data. The US and the UK data have not shown any serious pregnancy-related events. Pregnant women in India have also been vaccinated. And though this is anecdotal data, it is substantial because a number of frontline high-risk populations have been vaccinated without any serious adverse events. And a number of international bodies, the ACOG, the RCOG, FIGO, the Canadian Society, all support and empower women to be vaccinated in pregnancy and during lactation. Next, please. So I feel the greatest reward for doing is the opportunity to do more. And we have a brilliant opportunity to reduce risk in the pregnant population by offering vaccination to them. Next, please. I'll talk a little bit, maybe a minute or two, in a little broader sense about COVID vaccines and women's health. Just to clarify, they can take it on any day of the menstrual cycle. Pregnancy testing is not required. Women can take the vaccine in the month that they are planning to conceive because it does not affect fertility or miscarriage. And the next dose can be deferred to the second trimester once we have the permissions to give the vaccine in pregnancy. Next, please. As Dr. Ramani Devi said, for those who have planned on fertility treatments, either they can finish the vaccination before embarking on procedures. If they have not and the opportunity arises, it may be prudent to avoid it very close to the time that they are going to have general anesthesia or ovum pickup. In the future, when the vaccine is allowed, one could defer vaccination to the second trimester. If there are comorbidities, then we have to individualize. And if there has been a previous history of COVID for that particular woman, then same as the general population, one would defer it by 4 to 8 weeks. Next, please. What are we up against? And vaccine hesitancy is only part of the story. We are familiar with this infographic which got circulated on WhatsApp, that you can't take it on certain days of the period and so on and so forth. Completely steeped in irrationality. We also have to contend with fake news, the WhatsApp university, and plain old COVID idiots. So there's not much we can do about all of these except spread the correct information, spread the information in the right way, and motivate our leaders and the MOHFW to take the step in the right direction to empower women to take the vaccine. Next, please. So as Darwin said, it's not the strongest of the species that survives, nor the most intelligent, but the one which is most responsive to change. And we need to change our thoughts about vaccination. We need to change our thoughts of recommendations on vaccination in pregnant women to take this forward. Thank you very much, and I'm really sorry about this technical glitch. Thanks, Meenal, for operating the slides for me.
Thank you, sir. Welcome.
Thank you, sir, for your really comprehensive and an informative lecture. We really wish that the guidelines of the government of India are updated soon so that we can give that benefit to our patients soon. Thank you. Thank you, sir.
Thank you.
Can I set the ball rolling here by asking the two people who are in the government institute from Delhi, Dr. Achla and Dr. Aparna, what is the reason why there is a hesitancy? Is it because there is a slight increase in the clotting in the AstraZeneca vaccine? And is that the hesitancy that in the pregnancy the clotting risk may increase with the vaccine? What is the hesitancy? There must be some hesitancy. See, let us be very clear cut about it. That's what I wanted to know. What is the hesitancy?
They think because it has not been tried, so they're taking their time over it. But I think Aparna will know a little better because she's working with Nija.
Sir, actually, every vaccine has to go through something called a DART study, before it is approved for vaccination in pregnancy. This is a standard operating protocol for vaccination in pregnancy. Pregnancy is supposed to be a very sensitive stage, and no organization, at least in India, will take anything on there. So the moment this thing came into being, one day before there was a death in Brazil from from the Covishield.
From Covishield.
If there is one maternal death due to vaccine, there is a lot of confusion around it. So any organization working towards vaccination in women will think 10 times. Now, for the the other mRNA vaccines, the DART studies have been done, but for Covaxin and Covishield, the DART studies have not been done. So now here the entire decision has to be based on the risk benefit ratio. So it has to be explained to the women. So because these studies are not available, so there is understandably there is a delay because of the overwhelming risks to the pregnant women that is being faced in the second wave. So whatever decision, we have to really give credit to the people who are campaigning for it, because it is essentially a risk which is being taken by the organization which is giving permission. Because it is like, superseding the normal procedure of permissions for vaccination.
Absolutely. I think we are in unprecedented times.
Here in Alchemist Hospital.
So what I wanted to ask is my suggestion, because you are all in important places of the government. Now that a lot of healthcare workers may have taken the vaccine, and many of them must have been pregnant, without their knowledge. No, because when we gave the vaccine to the healthcare workers, we never told them to do the pregnancy test and take a vaccine. So they took it at random. So can we not do a retrospective analysis in those patients who became pregnant after the vaccine without their knowledge, and see whether there was an increase in the clotting mechanism? So whether a FOXY can mount a national big study, simultaneous study using the 250 societies, and along with the IMA collect retrospective data on an urgent basis, mount a social media campaign, and create a registry and collect the data and show it to the government.
So, sir, I think this is a very good suggestion. But at the same time, when we talk about safety studies of vaccination, we need numbers something like 80,000 to 1 lakh in terms of safety studies. But yes, what you're saying is very, very correct, because what actually happened is that the people who have done the Covaxin trial also, they actually, when they unblinded it and all of that, so they did find that some people were pregnant. But it really needs coordination from a lot of places to have this kind of thing. And it's a very good suggestion, something that can be done in the future. Yes, sir.
It's a good start. I mean, it would...
Can I come in? Yeah,
yes,
I have been regularly in touch with Nirja while the Integra meetings were on. And what is interesting is that while in the first Integra meeting, they were worried about the venous thromboembolism risk in women under 40 in UK. What happened was that there were 209 cases reported, out of which 45 deaths. And this was on the day in middle of early May when Integra meeting happened. Now that data was available, and there's not a single Asian woman in that list of 209. So it goes without saying that the risk of thromboembolism is much lower we all know that the Caucasian women are at a higher risk of venous thromboembolism than Asian women. And that's point number one. Subsequently, the Indian, and of course, the risk is 1 in a million there. The risk was the risk of having the clot was 1 in a million. The risk of dying from the clot was 1 in 250,000. A very low risk even in those Caucasian and Latino women. Subsequently, the ICMR has released the venous thromboembolism data with Covishield in India, and it's much lower. It's to the order of it's much lower than that. That's
0.6 per million.
Number one. Number two is that there is data available of Covishield vaccination in pregnant healthcare workers who took it inadvertently in UK. And the government cannot go and say that these are our vaccination in pregnancy guidelines. We are dealing with a pandemic. We are not dealing with a normal disease. It's completely, I think the problem is the government is worried about if a death happens, who is going to take the responsibility. And it is much more difficult to take a decision and stand by it, because even if you save 100,000 lives, the one person who's going to lose her life, that there would be a backlash, and government is unwilling to take that backlash, and that is a lack of leadership, I would say. The third important thing is, at least in Calcutta, when you go to take a vaccine, nobody asks you whether you are pregnant.
Same, yeah.
And I know that doctors' wives are going, who are pregnant, knowingly they're pregnant, they're going and taking the vaccine without disclosing the That is happening regularly in Calcutta. It has happened.
You have given a solution, Bhaskar, to all of us.
Absolutely. Just don't go and tell you are pregnant. The patient, we tell the pregnant patient that we are not going to advise you this thing, but you want to take it, just go and take it.
The thing is, there's news that US is going to supply Pfizer vaccine to India. Why can't Foxy ask the government that why can't preferably we give that vaccine to the pregnant women?
Dr. Ajit, I would say that given the storage requirements of Pfizer vaccine, it's very unlikely that you will be able to give the Pfizer vaccine anywhere outside of the big metropolis. You are talking of vaccinating. This time, rural India has been hit much worse than urban India. And rural India, people are dying without getting tested. And it's a common thread that people are dying at home of shortness of breath. No testing done, no hospitalization.
Anyway, it is going to come now. So that means
Pfizer, you will not be able to take it to rural India. It's going to be almost.
But I would say a good news is that one of our, I will not take the company's name, is about to launch it's in the phase 3 trial, the RNA vaccine in India.
No, Rishi, not in the next 6 months. I have spoken to the company, not in the next 6 months.
I see.
It's just entering.
Maybe next year. We have to hold on for that 6 months. Yeah.
Dr. Parikshit, I just wanted to ask you one thing, that suppose a patient comes who gives history of being overdue. So would you advise a pregnancy test before taking the vaccine or not? No pregnancy test?
So this is
but if she's overdue, she tells you categorically?
No, if the pregnancy is not diagnosed, then you don't have to diagnose it in order to give the vaccine.
But if she comes and says that I'm overdue, I have apprehensions whether I am pregnant or not, can I take the vaccine? Then I think it is mandatory that we should do the
so you do the urine test with the information given to the patient that if the test is positive, you are not going to be eligible to take the vaccine.
See, India's the other thing I wanted to tell you, Rishi, is
which is exactly opposite what Bhaskar advised us to do.
No. The other thing I want to say, Rishi, is that India has got quite a good experience with killed virus vaccines. And at least if the government wants to play safe, it can say that the Covaxin can be given to pregnant women. And that would not be a problem. There is a shorter supply of Covaxin, but you can earmark the Covaxin for pregnant women.
So the Covaxin doesn't have an increase in the clotting problem?
No, there isn't. There's no data, data on that. And there is no worry about, see, the problem is because of it is an adenovirus vaccine, there are worries whether there will be any congenital malformations or any fetal effects. With Covaxin, Aparna, am I right? With Covaxin, with being a killed vaccine, that worry is not there. So why, if you have the intent, why don't you go ahead and say, well, for the time being, we are saying Covaxin for pregnant women? What is holding government back on that?
Sir, in that case, actually it becomes, because whatever the government says, there is a lot of confusion then. And a single statement will lead to a lot of programmatic implementational issues. So when we know that the risk of Covishield is not very high in the Indian population, government, that is the main programmatic issue, that, okay, you are pregnant, you'll be given Covishield, because the availability of Covishield might be a limiting factor. So when you are rolling out a government program, just wait and, give permission for all vaccines. So I think that is, so whenever a situation is coming in where there is a confusion, it is better to wait for some time and roll out a statement which is non-ambiguous. So these are certain issues in programmatic implementation, a countrywide programmatic implementation, and that is where the delay is happening, sir. And I think that is well judged. But I think people are acting really, in the interest of pregnant women, and people are really working hard. So I'm sure very, very soon something is going to come out, and I'm really positive about it. Yeah.
No, we were sure that it would be approved on the 13th of May. I think it is a death in Brazil that occurred on 11th of May. I think it turned the tables. But
no, but the gynecologists on the panel really worked hard to prevent.
Absolutely, we know that. We know that. And I think she was pretty sure on 13th it would get approved.
But now
I think we made a step in the right direction by having it approved for the lactating women at least.
Yeah.
But the pregnancy also is on the anvil and should be there anytime soon. Yes.
I think, one thing which we have to learn the Foxy leadership from this is that we need to as the Foxy in areas of where there may be a controversy or there may be a hesitancy, not that government is against it. We need to take more responsibility. Like, for example, in family planning, where there may be the fear of retaliation during election. So Foxy, being a neutral body, should have more responsibility. And we must strive to see that next year, when there's a vaccine committee, Foxy representative is there on the committee. We have to make a representation. I'm going to make a personal representation to the PMO's office that this will not do. When we are the custodians of women's health in the country and we are willing to take the responsibility, the federation has to be represented. True. Wherever possible.
I think we should probably move on to the panel.
I know the dilemmas of COVID are never ending, never ever ending. And I think there were fabulous 3 talks, and there are so many people still logged in. I think over 2,800, and the questions are overflowing. There are more than 150, 200 questions, and everybody are asking the same thing. Vaccination is a hot topic right now. So much is flowing. I think we carry forward the discussion by discussing more points in the panel discussion. And I welcome all the panelists today. Let me have the slides. Minal, can you please share? I invite all the esteemed panelists, Dr. Lakshmi Shrikande. Dr. Lakshmi Shrikande is a chairperson designate ICOG, that is an Indian college. She is a medical director of Shrikande Fertility Clinic, Nagpur. Can you make it full screen? Yeah, and she's the national corresponding editor of Journal of OBGYN India and national corresponding secretary, Association of Medical Women in India, and a founder, patron, and president of ISOPAP Vidarbha chapter. She has a lot of achievements and a lot of prizes, and a very dynamic person from Vidarbha doing a lot of work in Foxy. Welcome, Dr. Lakshmi Shrikande. Please, may I have the slide of Dr. Achla Batra? Dr. Achla Batra is a current president of AOGD, and she represents the Department of Obstetrics and Gynecology, VMC and Safdarjung Hospital, New Delhi, president of Narchi, Delhi chapter 2018-20, chairperson Eurogynac Committee of AOGD, and is also the chairperson of Rural Health Committee of AOGD. A lot of academic achievements. She has been a PG teacher for more than 35 years and an immense work in this COVID times also. So definitely we are eagerly waiting to hear from you, Professor Dr. Achla Batra. Welcome. Next.
Komal.
Yes.
Komal, the most important thing on her CV was missing. She's the current president of AOGD.
Yeah, I said that.
You said that.
It was there in the block, President AOGD.
Okay.
Yes. So, may I have the next slide? I welcome Dr. Aparna Sharma. Aparna Sharma is an additional professor in the Division of Maternal and Fetal Medicine, Department of Obstetrics and Gynecology, AIMS, New Delhi. And she has been a fetal medicine specialist with expertise in fetal intervention, Kaminida orator, and a Foxy Junior Category Corion Award winner. She has delivered a lot of COVID positive mothers. In fact, she was a pioneer. First COVID positive pregnant mother was delivered in AIMS under her guidance. So welcome, Dr. Aparna Sharma, and I'm awaiting to hear your contributions. I call upon Dr. Ajit S., who is an additional professor and HOD Department of OBGYN, CMC Kannur, KFOG President, past Vice President and Joint Secretary of KFOG, and past Chair of the Research Committee of KFOG. And he's also the coordinator of Maternal Near Miss Review. So that is really nice to have you on the panel. And we would definitely get the inputs from the south of India as per the COVID is concerned. And I also welcome Dr. Biswajyoti Guha, who is a consultant obstetrician and gynecologist from AMRI Hospital, Mukundpur, Bhagirathi Neonata Hospital, Newtown, Joint Secretary of BOGS and a council member of AICC RCOG East Zone. Honorary Secretary of ISOPAP Kolkata chapter, and also an examiner for MRCOG. And he is a very good and excellent academician. So welcome Dr. Biswajyoti Gua. And with all these eminent panelists which I had, I'm awaiting a very carrying forward the lovely discussion which we have been doing regarding all the talks, and we carry forward and discuss practical aspects like day to day, how we encountered patients and how we are going to find out about the management. Is it seen? So we are going to discuss about what are the actual do's and don'ts and how we should manage all the COVID patients which we are encountering in day-to-day practice by chance or coming with symptoms of COVID. So as of 6th June, that is today, worldwide, this is a strategy of all the cases, and India has actually the cases rising so high. This is the statistic, and Mumbai alone has around 7 lakh plus reported cases with almost 14,000 deaths, and India has reported 3 lakh 41,000 deaths. So India being the second highest leading contributor of COVID, and COVID is not escaped our pregnant women, and so many pregnant women are coming with COVID symptoms. So I would like to begin asking Dr. Achala Batra that we had discussion about ANC care, but just to sum up, some viewers must have joined a little later. So what are the classical effects of COVID on pregnancy?
Basically, COVID doesn't have effect on pregnancy. It has, like it will not affect the fetus. It will not be transmitted to the fetus. But because of the pregnancy, from raised up, respiratory reserves are less. So there is more severe disease, and because of the disease severity, we have seen more preterm labors and neonatal deaths because the disease occurred in the preterm woman, and also because of the COVID, there were more of intrauterine death because the mother was sick, not because the COVID caused it, but it was the effect of the hemodynamic condition of the mother which caused the stillbirth. And if you have, fever, if there is high fever in first trimester, we know high fever in first trimester can cause anomalies. But it's not the COVID which is caused. It is the manifestation of COVID, which could be fever due to any reason, but COVID also causes high fever. So it can be more abortions because of that, not because of COVID. So basically, COVID per se doesn't cause anything, but pregnancy and COVID together, there are a lot of effect on this.
Yes.
And we have seen, though not reported, that a lot of our patients had, severe preeclampsia and GDM, but we don't have any reports of that. But we do have a lot of patients with COVID who had GDM and preeclampsia.
Yeah, very, very good. That definitely when we have the now data of almost a year apart, we know that the only cases what we are seeing is the adverse neonatal outcome because of the maternal condition. What about how does the pregnancy affect the progression of COVID? Like if a pregnant patient becomes COVID positive, what is the progression in the pregnancy? Dr. Ajit, you can add.
Actually, there is no much adverse effect on the pregnancy as such COVID-19. The only thing, as Dr. Achala mentioned, the preterm delivery. It does not cause any miscarriage, any congenital anomaly. But when it is a severe infection, there is a more need for invasive ventilation, more need for ICU admission, and even more death also we see, especially in the second wave. We are seeing more death because I am saying this because each maternal death in Kerala, we have a confidential inquiry, just like what is happening in UK. So the last wave or the 1 year only we had 7 deaths. But in the second wave, over the last 3 months, we have 27 deaths, which we analyzed 2 days back. And severe infections, the more commonest cause of death is actually the COVID pneumonia. So when it is a severe infection, if it is a asymptomatic infection, no problem. But if it is a symptomatic infection, there is a more chance of the disease progressing to severity and even a maternal death can occur.
Yes. Dr. Aparna, you come from AIMS. So, Percy, what is your impression about patients having comorbid conditions like obesity, diabetes, or heart disease, and having COVID positive? How is the outcome in those patients?
Yeah, so definitely patients who have had comorbidities, definitely the course in them becomes much more complicated. So even at the first contact of a COVID woman, a COVID positive pregnant woman, even if it's a mild disease, the first thing that we really need to look into is the comorbidities, because that will really determine the outcome. So because ours is a referral center, so we do get all kinds of complicated pregnancies. So we do see more complications. Recently, we had patients with, Takayasu's arthritis with COVID, pancreatitis with COVID, heart disease with COVID. So all of these do have little more morbidities, getting more complicated. So I think some of these things are something that we really have to keep in mind and, manage them, admit them, monitor them more carefully, because they have more adverse pregnancy outcomes.
Yes. So definitely all over the studies have also said that women with
the three groups, I think the elderly women, obese women, and these women with diabetes and hypertension. Yes. These are three groups where there is a high risk.
So we need to remember and classify the women with pre-existing medical disorders and be very vigilant when COVID per se complicates their pregnancy. Effects on fetus, Dr. Bishwajyoti, I've seen a lot of any effect teratogenic or any effects on fetus, any data?
Thank you, Dr. Chauhan, for having me in this panel. The effects on the fetus, it's very early to speak about the effects on fetus, but what I could see from the literature that I recently had to go through, the one that was published in BJOG 2020 July, that was an application from Chinese. That was actually COVID 1.0 publication. So in that case, in Wuhan and the surrounding areas, what they found was the effect on the fetus was almost nil. The only thing that COVID affected was the pregnancy. And in pregnancy, what happened was preterm labor. And as you rightly, Dr. Ajit rightly pointed out, that congenital heart defects and people who had complex congenital heart defects, especially or with comorbidities, there the risk of preterm delivery was much more increased. So the only thing that congenital malformation, we don't know, but risk of preterm delivery prematurity is certainly increased if you have a severe COVID infection.
Yes, very well said. And also when we talk about vertical transmission, also there are no reports actually showing that there is a evidence that there is a vertical transmission. In fact, there were studies done with the vaginal secretion also was being tested if it is COVID positive. So whether there is a vertical, even the breast milk was being tested for COVID positive. So, but there are no recorded actual reports coming in. So still there is a query when we talk about vertical transmission per se. When COVID is concerned, and I think we require more and more studies coming to know this. But now I would really ask all our panelists.
Can I add that vertical transmission? Yes. Again, we are doing a multi-centric study in all of the medical colleges in Kerala, and what we found is about 14% risk of vertical transmission. Not that vertical, whether it is a vertical transmission or not, 14% of the babies are becoming positive. But all these babies were fine. It does not cause any problem, just COVID positive. 14, that is the number we noted.
That is a very high number.
Yeah, 14.
I think we require more studies like this to know, because that will actually tell us the vertical transmission, which we are really worried about. So interesting. We'll wait for the more studies to come in. Now I want to ask Dr. Achla Patra, is there any difference in the first wave and the second wave? Because we know we had a first wave, we have spoken, but practically what is the scenario? What about the immunogenicity or the mutant strain or some different symptomatology or something that way?
Definitely, there was a big difference between the first wave and the second wave. Second wave, we had more number than that is probably proportionate to the number of people who were infected. But the kind of things happening to the woman, they would come and suddenly they'll go into respiratory failure. They will be just mild to moderate disease, and 2 days we'll have them dead, Suddenly it will be affecting the virus. This time was quite bad. It affected the respiratory system very badly, and we had many mortality in 2 months in 4 government hospitals. I could find out, that out of the 10 women died in 2 months, out of all the women who came, about 1,000 or something, 10% mortality was there of all the COVID patients who came. In the first wave, there was not so much mortality, and even the morbidity was also less, and mortality only occurred in women who had comorbid conditions. But in the second wave, hale and hearty, young, not hale and hearty, but young women without any comorbidities, we lost them. The second wave has been taken a toll very badly of pregnancy.
Yeah.
And probably it is because of the immunogenicity of the strain, or maybe it is more thrombogenic, it is affecting the system more badly, because it has been seen even non-pregnant young males are also, taking the toll of this, and we have seen many deaths in young men also.
Doctor, scenario around in the south, do you still see that the second wave has the more immunogenicity, and this mutant strain is really very dangerous? Because we heard a lot of some places in South India were having a very deadly strain or something in that way.
Second wave is completely different. Actually, it's more symptomatic patients we are seeing, and again, the effect on the fetus. The placenta is infected. There are reports of placenta infections. So maybe the blood supply to the baby may be affected. So there are reports of FGR and even stillbirths also, even though there is no evidence that the stillbirth is increased from studies. But we are getting reports of stillbirth also in patients with the COVID.
So placenta, are you doing some study on the placenta of COVID? Because I just want to know, because you said about placenta being infected.
Yeah, there are some reports coming.
That is very interesting to know.
So can I ask Dr. Ajit, are you taking the swabs from the placenta itself?
No, not till.
No.
We didn't get any that is support from the government to take a swab from the placenta.
Yeah.
So how do we know whether the placenta is getting infected?
There are some reports from outside coming. The only thing is the placenta.
So we need to have our own reports, because
we need more studies.
What Dr. Kamal is that this time what we are seeing is a lot of the immunogenicity of the virus is much higher. Or what I should say is that the infectivity of this virus is much higher. So people are getting much more infected in this current 2.0 or whatever the second wave virus is. It's very much more infective, and pregnant ladies who have walked in our clinics, the next day they call me up saying that I have turned positive. So it is a difficult situation that we are facing today.
Yes, it happened when the wave was about to start in Mumbai. That was the first it came in India, and we used to have any patient just coming pregnant, and we used to do their rapid antigen test. It turned out to be positive, so it was really very prevalent in second wave. But and we have seen some adverse outcomes all over, as all of you have said. So now we have discussed about this. Now, Dr. Aparna, what are the current guidelines on testing? Because every time we are doing testing whenever a patient comes, but what are the actual guidelines? How often do we test, and what are the actual guidelines? Which test to be done? Which is the gold standard?
Yes, so I would say that number one is that first of all, we test whenever a patient is symptomatic anytime in pregnancy. So I think that is number one guideline for the antenatal period. The other thing is that whenever a patient is coming for delivery, so I think most of us are testing at the time of admission to hospital or healthcare facility for delivery or any other procedure. So these are general recommendations that, and because whenever a patient is coming for the admission for except for delivery or cesarean. Now, which test to do? There are three types of tests. So the number one is RT-PCR, which is actually the gold standard. The other one is the rapid antigen test. And the third one, which is available, is the CBNAT or the TrueNAT, which may not be available everywhere, but it is the third one. Now, RT-PCR is the gold standard, and the report might take some 24 hours. Some places it is 3 to 5 days also. But if you have time, it is an elective induction, elective procedure. It is an ideal test to be done, and it has got the highest detection rates for COVID. The other one is rapid antigen test. What we need to know is that if the test is positive, then you have COVID. But if the test is negative, but you are symptomatic, it does not mean that you do not have COVID. So it has got, so this fact remains very, very important in terms of testing. Now, the third test that is available in some of the centers, and we commonly use that test, is the CBNAT or the TrueNAT. It is actually come from the TB testing, which is available. So the centers which are equipped with that are completely, metamorphosized into the CBNAT test. And this is especially useful for patients who are coming in labor. So this test has accuracy of almost RT-PCR, and it is available within 2 hours. So it is not done in mass, large numbers, but it can be done for individual patients, and it is available again in 2 hours. So in our setup, we do CBNATs for patients who are coming in labor, and we want rapid testing with accuracy also. So this is the third level of testing which is available. But for all practical purposes, if you have time, if you have elective testing, the gold standard remains RT-PCR. If you do not have time and if you do not have the facility, please go for RAT, rapid antigen testing. But please remember that if you are positive, you are positive. If you are negative, but you still have symptoms, please treat the patient as positive and, isolate and manage accordingly.
Yes,
and in Komal's second wave, many patients were symptomatic, but RT-PCR came negative.
Yes.
So it is the clinician's perspective that based on the symptoms, if you feel like that she is COVID positive, I know it's very difficult for patients to accept, but we have to tell them that your symptoms are more towards COVID positive, though your RT-PCR is negative.
Another indication for testing we are keeping, if somebody has, just a day before somebody in the house has COVID positive, then also we are testing when they're coming to us. Besides coming in labor or for any admissions, or if they have symptoms and the contact of COVID.
Yeah, yes, ma'am. Just like Dr. Achla Batra ma'am has said, so suppose you've had an exposure to a patient.
Yes.
So that is the third indication where then we have protocols for when you should test. So if you have had an exposure to a patient, so this is something called a quarantine that you should go. So here, if you have time, I'll just mention quickly 2 things. Now, initially we followed 2 protocols, low risk exposure and a high risk exposure. If you have a high risk exposure, you test, you follow yourself, quarantine yourself, test yourself on day 5 and day 14. Now, in the healthcare facilities where most of the doctors have now become vaccinated, now we follow the CDC protocol of high risk stratification testing, where after vaccination, after you have got an exposure to the patients, you will follow yourself symptomatically and test if you have symptoms. So this is the second method of testing. So there are 2 different protocols for testing, separate for household contacts and for those who are vaccinated. So for household contacts, if you are a high risk contact, you can test yourself on day 5 or day 14. Skip day 5 if you are, you don't want to do 2-minute test, but at least day 14. For healthcare workers who are vaccinated, follow the CDC high-risk stratification protocol where you will test if you are symptomatic, because you are following universal protocols of using N95 and taking all precautions. So that is our protocol.
Yes, very nicely explained, because every time the dilemma is that everybody are very confused regarding testing and getting the test results right on time. So as Dr. Lakshmi Shrikante madam also pointed out, that there are sometimes the tests are not revealing the RT-PCR. What about these markers? You can add, Dr. Lakshmi, on the role of these markers, that is CRP. We are relying too much on this for correlation or for prognosis. So what is your take on it?
Yes, I will definitely like to point out that we should not do unindicated, the times when it is not indicated. For indicated patients, yes, you should go ahead and do the markers. But if you feel that the markers are not going to affect your management, then please left, right and center don't advise these tests to your patients.
What is the take? Because most of them, I think, even the younger, even a 14 or a 15-year-old will get COVID. They will get they go to a doctor. All these tests are done, because I think that is a normal practice. So what is your take?
They also do on their own because they have read it on the Google, but it should not be misused, because sometimes doctor, you get confused how to treat, what to do.
Dr. Ajit, you want to add?
Asymptomatic patients, we should not do any test. If it is a tame patient, okay, D-dimer may be one option we have. Otherwise, we don't do any test. Then any symptom, any respiratory symptoms, we take a chest X-ray. It's very important. Then any symptom, any fever or such situations, you have to go for the inflammatory markers.
Just Dr. Kamal, can I just come in for 1 second?
LDH also we do.
Dr. Kamal,
Then if the pulse rate is more than 110, it is mandated to do a ECG.
Okay.
We do ECG if the pulse rate is more than 110.
Okay, well taken. Yes, Dr. Biswajyoti.
Yes, what I was thinking was when we request D-dimer is anyway raised in pregnancy. So when we get pregnant ladies in which who have COVID, and if she's mildly symptomatic COVID, I would not recommend D-dimers because that is anyway will be raised in pregnancy, and anyway we will start her on low molecular weight heparin. But CRP interleukin 6 only for those very much, interleukin 6 only reserved for those severely ill COVID patients or people who are coming with COVID pneumonia. And of course, CRP and ferritin should be done. That is my take on that.
D-dimer, actually, we have a different cutoff value in pregnancy. In the first trimester, if it is more than 1,500 or 1.5, or in the second and third trimester, we take 3.5 as the cutoff. If it is more than 3.5 or 3,500, whichever the units we use, more than 3,500 or 3.5, it is serious.
Yeah.
That means we have to go for a higher dose of anticoagulant.
Agreed.
As for pregnancy, for D-dimers, we'll have to take, how the pattern is going. Suppose even if you have a lower side value and you are suppose doing it and you repeat it and you find suddenly that it is high, then that has more significance, just at 1 point value. Definitely, like values, like you said, more than 3,500, that patient would be sick. But otherwise, it is when you're following, it is the values which are seen, they are more important than single value.
Because this anticoagulant, the heparin is the one that makes the difference in the mortality. So whether to give the prophylactic dose or therapeutic dose, so that has to be determined by the D-dimer value and the VT scoring. So D-dimer has a place.
So when we have a symptomatic patient or we have an obese patient or something patient, then definitely we rely on these markers and we try to do. But how often do we repeat them? Because that is also a very important point, or do we repeat or do we not repeat if the patient becomes asymptomatic? Dr.
And can I say something?
Yes.
So there are two aspects to these testing. Number one is whether we start anticoagulants, and number two is when do we start steroids. These are the two aspects why we would do markers. So in AIMS, what we follow is that for asymptomatic or mild, we don't do testing. But patients who are having moderate to severe disease, anyways, we would be starting anticoagulation. So we are not doing these tests for anticoagulation. What we are actually doing these tests is in those cases of mild COVID who are not subsiding, even after 5 to 6 days persistent fever, in which we would be considering steroids, right? So we have to, it is not the single marker which is important, it is the trend which is important, and it is to be repeated in 48 hours. And in all markers, suppose you are, you don't want to offer all, what is most important that we commonly do is only CRP and D-dimer, because one marker, 10 markers, the report or the interpretation will remain the same. So we just do CRP and D-dimer, understand the trend, and start steroids or don't start steroids. So that is the only thing that we need to see, because anticoagulation, we start for all moderate and severe. And we will continue anticoagulation till the disease severity is persisting. Anticoagulation is not dependent mostly on D-dimer, except in very few cases of mild where there is nothing else but raised D-dimer. So in most cases, asymptomatic and mild, these markers are not required. These markers are required mostly in cases of, to see the progression of disease severity in cases of moderate to severe, where we have to repeat in 48 hours to see the trend, whether we want to, see the steroid therapy, response to steroid therapy, or you want to add something else, especially IL-6, if you want to add something like a IL-6 inhibitor or something like that.
Yes. So very rightly that when we have a choice, we stick on to 2 markers and repeat it depending on the treatment or 48 hours. That is the message. But what about X-ray? Because we are dealing with pregnant patients. So what is your take on X-ray and HRCT? What is the correlation of the CT value on HRCT and the progression of disease? Dr. Achla, I'll go with you.
Doing an X-ray or HSCT also is dependent upon the condition of the patient. If she is maintaining her oxygen saturation, if she, even after her walk test, she is maintaining her oxygen saturation, then there is no need of an X-ray and HRCT. And whenever the condition demands, if she is not maintaining her oxygen or she is becoming breathless, then X-ray or HRCT both can be done, and without any effect on the fetus, because the exposure is not so much that it will affect the pregnancy.
Yes. And Dr. Biswajyoti, can you tell us about the CT score, like how we should calculate in our pregnant patient, and what is the significance of that CT score?
The CT score, what has come out is that CT score has got some definite value regarding the severity of the disease. So if the CT score comes out as low, then the severity of the disease is increased. But to be very honest, in mildly symptomatic, and it depends on the reports from where the reports are coming in. So if you do a RT-PCR from a government setup, they will hardly give you a CT score. But if it is done from a private setup, especially happens in Calcutta, they will probably give you a CT score, and that is an indication of how severe the disease can become. But to be honest with you, I got a lady who had a CT score about 25, 26, but she had fever for 14 days on continuously. Mm. But just fever, and oxygen saturation, she did not desaturate at all. But she had fever for 14 days, and we had to ultimately, and she was started on steroids, but still the fever persisted. And ultimately it decided, but it took quite a long time. And the fever was very low grade fever. So we could not ignore, and we could not discharge. That was the main problem with that.
Yeah. Dr. Aparna, what about, have you encountered such patients with a negative RT-PCR but a positive CT finding?
Yes, RT-PCR can be negative, but in between, when the labs were mostly overburdened also, and the RT-PCR would take a lot of time, and there were a lot of times when reports would not come. Patients were very classically symptomatic, so in those situations CT would help. But I would really say that it is more of clinical finding, saturation, persistent fever, saturation following tachypnea, which really guides the management. So we've had patients who have actually done CT on alternate days without actually changing the management. Yes. So I think CT scan does not have much of a role. And I think any physician you talk to, we will completely agree with this, that, it does not really change much of a management. And it is more of the clinical improvement along with the markers when the disease actually reaches the moderate to severe stage, and see how things are and how the oxygen requirement is, which is more indicative rather than a CT finding. So if sometimes, and we have seen that during the peak of the phase, RT-PCR reports would not come, and then the diagnosis was made on the basis of a CT. But beyond that, it is not, to be then. But of course, if it is there, it is a reliable finding. Definitely, I would say that.
Because even I had a couple of patients in whom we suspected COVID, but the RT-PCR kept coming negative. But later on, when CT was done, it was showing all the ground loss, opacity, and everything, and even with the race CRP. But the RT-PCR never came positive. So there are some patients also, I think, where we have to actually rely. But can we call them COVID just by CT diagnosis? That was always
yes. So this is the most important thing here, that if there is something CT which is very, very corroborative, we have to treat. See, there is no treatment for COVID. It is all symptomatic management. It is all supportive management. So we just have to monitor the oxygen. We have to monitor the saturation, and then manage the symptomatology. So yes, and these things have been done. So I think there is no there is no two ways about it, that CT has been a huge help, but not repeated CTs. So this is something that it does not help in disease progression or, monitoring. It is just, a one-time thing that can help.
Yes. Yes. And only clinical thing when the oxygen saturation
is the clinical condition of the patient.
Yes. It's very important. When the oxygen saturation is maintained, then there is no role repeating.
You have to go by the clinical condition of the patient, the oxygen saturation, the tachypnea, which will help you.
Yes, very rightly, Achla madam. So coming to the drugs. So Dr. Lakshmi Shrikandi, what are the drug options we have for COVID? because so many times everybody is waiting for the treatment for COVID. So what are the drug options which we can give to our pregnant patients for COVID?
See, even the Google is flooded with this, and even our government has put up the large hoardings that what patient can take at home. So yes, definitely, because it's an inflammatory disease and everyone has to boost the immunity. So there is no harm in taking multivitamins, zinc and vitamin C. And of course, I have read papers that vitamin D also has an important role when it comes to COVID-19. So we can give, as these don't have any side effects.
Yes. Commonly, when we talk about the safety issues, Dr. Ajit, what would be the drugs which we can actually say that in pregnancy we can give, which are recommended for COVID and which are strictly no?
About the treatment, even in asymptomatic patients, if it is near term, I think the low molecular weight heparin has to be considered unless she is going to deliver within 12 hours. And we continue this low molecular weight heparin even after delivery. And then at the time of discharge, we give it for 10 more days because there are some deaths which had happened in the postpartum period on the day 10 and all these things, even in asymptomatic patients. So asymptomatic patients also, one common drug that is commonly used is the low molecular weight heparin, unless she is going to deliver within 12 hours. Then about the steroids, we don't give steroids within 5 days. Only after 5 days of start of symptoms, and if the inflammatory markers are raised, then only the steroid is given. And again, which steroid we use? If you want the lung maturity, the one that is used is the dexamethasone, the same way that we give for the lung maturity, that is 6 milligram, 12 hourly, 4 doses. But we don't continue with the dexamethasone because if you give dexamethasone for a long period, it can cause fetal adrenal suppression and it's not that good. So we then convert it into methylprednisolone. Again, the dose is 0.5 to 1 milligram, and the common dose that is commonly used by us is 40 milligram IV OD. And the total duration of steroids is 10 days. And if it is, again, symptoms is persisting, then we may have to give steroid for a long period, but then we have to taper it. Otherwise, if you are giving the steroids only for 10 days, there is no need for tapering the dose. Then about the remdesivir, it is used on a compassionate basis after taking informed consent. It is not recommended in pregnancy, but may be useful, even though WHO says that it is not useful, all these things. We are using remdesivir. Again, it should be used only within 10 days of onset of symptoms. More than 10 days symptoms, remdesivir does not have any role. So we use remdesivir within 10 days in moderate or severe cases. Flavipiravir, we don't use. Ivermectin, we don't use. Then azithromycin, okay, patients with the respiratory sore throat, something, we may have to consider azithromycin. HCQS, no place. Doxycycline, no place. Again, paracetamol, it's a very good drug. It has to be given to suppress the fever. Then ibuprofen should not be used. Prednisolone, again, the steroid, if the patient can take oral steroids instead of IV methylprednisolone, you can go for prednisolone 40 milligram OD. Aspirin, again, I don't have any experience.
Yes, very. Yes, I think you have summed up very nicely all the drugs. Yeah, I think all the drugs are very nicely summed by Dr. Ajit. But as Dr. Lakshmi Shrikande also pointed out, the role that because pregnancy is a special condition, and if we can give them more of vitamin D3, B12, there are many studies which shows that the vitamin D has an anti-infective, anti-inflammatory, and immunomodulated functions, and it also contributes to maintain the cell's barrier, uh, uh, the physical barrier integrity, and it enhances the activity of innate immunity, macrophages, monocytes, T cells, and that is really very important when we give vitamin D and also vitamin B12 because it has as a co-factor in DNA synthesis and also known to inhibit the viral replication. So this vitamin D and vitamin B12 is something which we can actually offer to all our pregnant patients, and we are actually giving to our pregnant patient, but more emphasis can be done when COVID is concerned. Also, there were studies which I just wanted to just quote that there is a hemoglobin alteration during the SARS-CoV-2, and this study shows that there was a preliminary paper about the viral inhibition of the heme metabolism by binding of the beta chain of hemoglobin through surface glycoproteins, and that is where they said that even WHO also recently have taken into consideration that there are a lot of blood changes with COVID-19. So giving an iron supplementation, because the ferritin level is something which is affected. So giving even a proper iron supplementation in form of ferrous ascorbate is really very effective when we are dealing with COVID patients. Definitely, we are giving iron to all our pregnant patients, but a specific study which was done, I just wanted to quote in the International Journal of Clinical Obstetrics and Gynecology. So recommendations we have all spoken. So let's go to some case scenario very rapidly. So Dr. Lakshmi Shrikande, we have a 35-year-old primary gravida, asymptomatic with SARS-CoV-2 RT-PCR positive. Does she require admission?
No, she is asymptomatic. Just because she is pregnant is not an indication for admission.
Definitely. So I think everybody would agree that do we admit just because she is an RT-PCR positive, or we tell her to go home?
35 weeks pregnancy, I think even if she's at home, we have to give some advices. The most important thing is sometimes the problem is if there is a cough or something, she neglected. If she becomes symptomatic, immediately she has to come to the hospital. That information has to be given to the patient. Another thing is she should have a pulse oximeter in the home where she has to check the pulse oximetry twice a day. And if the oxygen SpO2 falls below 94, immediately she has to come to the hospital. Another simple thing what we do is we ask the patient to do a 6-minute walk test or 40 steps. And if the SpO2 falls by 3%, immediately she has to come to the hospital. And we tell them to take a lot of water and you don't take bed rest because to prevent the thromboembolism. So these are the advice we give to these patients.
Yes. Very, very rightly we have covered how to monitor and the treatment. Anything specific you want to add to a treatment or repeat the test? Dr. Bishwajyoti Guha?
Yes, I would not, if she's 35 weeks primary gravida and she's asymptomatic and she stays asymptomatic, after 14 days, I don't think we need to repeat the test. But of course, if we need to deliver her or if she comes back in labor, then we have to do something. We need to know, as Dr. Sharma was saying, that we do test everybody who are in labor. If she comes to us in labor, we'll have to test her and treat her accordingly. And likelihood of her being negative is much more because she's already been positive. So 14 days later, I don't think we need to do any testing. We just have to wait and watch. If she's asymptomatic, she gets cured on herself only.
Yeah, and after 10 days, because Dr. Aparna, can you say if the patient required admission for some reason, maybe because of some obstetric indication, and then after 10 days, can we discharge her or do we have to repeat a test, and how do we advise her on discharge?
So I agree with Dr. Guha in the first place that we don't usually repeat the test after 14 days. So we will consider 14 days as end of isolation and consider it as negative. However, on the second admission to any healthcare facility, it is advisable to test. So we all know that the SARS RT-PCR can remain positive for a longer period of time, and there could be asymptomatic viral shedding, and it has been reported to be infective even up to 28 days period. So generally that is an understood cutoff that is taken. So a repeat test is done if the patient is getting admitted again. Also, after delivery, we generally discharge the patient within 3 to 4 days, even if the patient is COVID positive. So after normal delivery or cesarean section, we do not need to keep the patient admitted for 10 days if the patient has a mild infection and does not require admission for her disease per se. If the patient is stable, the mother is stable, the baby is fine, we discharge the patient on day 3 or 4 according to normal or a cesarean section. And at home, we say that we advise isolation for 10 days at home with all precautions, and how that she should be breastfeeding her baby with all respiratory precautions, droplet precautions, and also she should be isolating at home from the other family members who should be helping her with all the necessary precautions. So this is what she should be doing at home. When we are discharging the patient, we should explain danger signs to her, which has already been mentioned by Dr. Ajit, that, in case you have respiratory distress, if you have persistent fever, if you are having anything which is, even, bleeding and the usual danger signs, you should immediately report. But otherwise, you please send the patient home, and at the end of 10 days, you consider end of isolation and continue normally.
Yes, very rightly, because sometimes when the patient becomes COVID positive, everybody has a dilemma now what to do. So we'll move on to the second case scenario because we are just trying to touch on the frequently asked questions which the viewers may be having. So this is a Gravida 3 abortion 2 with 10 weeks of gestation and was tested RT-PCR positive and had received tablet flavipiravir and doxycycline and ivermectin. Dr. Achala Batra, so what about the drugs? Are these drugs safe in pregnancy? And will you advise our MTP?
Well, when you called drug safety, all these drugs are not recommended to be given during first trimester. But if she has taken them inadvertently, then there is no very definitive data to say that they will cause anything to the fetus. For FabiFlu, there is some animal data is there that it causes death of the embryo, but about anomalies also some data is there in animals, but in human beings probably it's not been used. There's no data. Doxycycline will not cause anything, and ivermectin, again, we don't have any such data that it will cause anomalies. So we have to tell the patient she has already had 2 abortions. Maybe she's very keen about this pregnancy. So we have to tell her that we don't know. There may be, no, it's not been reported. She can follow up with ultrasound and later on to see if there is anything wrong. If she wants to continue pregnancy, we will not advocate that you get an MTP done. We will leave the decision to the patient, telling her that we don't know, we're not sure about the data, but nothing has been reported so far in human beings. And from our side, we'll not advise MTP, we'll leave the decision to her.
Komal, you are muted.
What about remdesivir? So when we are using remdesivir, have you seen any adverse outcome with it? Dr. Aparna?
No. So remdesivir has been given a compassionate use clearance by SMFM also. So among all of these drugs, actually remdesivir is relatively safer. If you look at doxycycline also, as ma'am said, that it is, it is category C. Ivermectin, safety not established. Favipiravir, safety not established. But ultimately, the decision remains with the patient. So we have to tell them that, it is not known what happens. MTP would be a little drastic, but yeah, be careful, follow up with the routine ultrasounds and see what happens.
Yes. Jeet, you want to add something? How do we do investigation for the fetal well-being in this patient? Because she's really anxious. She had 2 abortions and she doesn't want to take a chance in this pregnancy. She is thinking that there will be more prone to again abortion with all the drugs she has taken. So how do we monitor her pregnancy as per se the fetal well-being?
Nothing like that. Just like a normal pregnancy, we monitor. We have to do anomaly scanning, all these things. That's all.
Probably will need more frequent scans for her. After 2 weeks, we do a scan, and probably we can follow her with more scans to see if something wrong is happening instead of just doing those one scan we do at 20 weeks and one at 11 weeks. Probably we could do more frequent monthly scans.
So when we close monitoring, Komal, and COVID positive at 34 weeks, 35 weeks, I mean, it has been reported that they really have some problem with the fetal distress. So I will definitely advise close monitoring, considering that she was COVID positive at 10 weeks of pregnancy. So how her pregnancy goes, I mean, needs close monitoring.
Yes. It's very, very well put up that we definitely need to just close monitor, and there is a management per se for the pregnancy doesn't change because we have been taking care and doing fetal surveillance for all our pregnant, high-risk pregnant mothers. This is a solidarity trial which I wanted to quote, and it was a trial of remdesivir given to pregnant patient, and they had almost 67 pregnant women, and even some were given in postpartum, and they found that there were increased rates of preterm delivery when remdesivir was given. So this consideration we need to keep in mind but remdesivir can be given in. They have also said if the benefits outweigh the potential risk. Only thing the question is about preterm delivery. So we need to keep a close monitoring on this patient because they have high chance of going into preterm delivery. Also, there was studies which were quoted in the Journal of Reproductive Immunology regarding the immunomodulating action of progesterone. So they said that a progesterone has a triphasic shift of immunological response, which is a pro-inflammatory in early stages of pregnancy, anti-inflammatory throughout the rest of the pregnancy, and pro-inflammatory in the peripartum and postpartum period. So they had some role which they said these patients having the risk of preterm deliveries or miscarriage would benefit from progesterone. I think it's a study which is ongoing, and this is all related to the anti-inflammatory response. So giving exogenous progesterone showed enhanced repair of the pulmonary epithelial cell, supporting a role of the steroid hormone in reducing inflammation and promoting faster recovery. That is what this study quoted. So we need to consider, because we have been giving progesterone for preterm labor, the same treatment which we can give to our patients who are also having COVID. So the management per se doesn't change when we are managing preterm labor of COVID patient. So coming to the third scenario, this is a patient, a Gravida 3 Para 2 living 2 with previous 2 LSCs. She's a 33 weeks with fever and cough with derange markers and HRCT. Severity score is 18/25. So definitely we know. So what about the admission indications? Dr. Achla will go with Dr. Lakshmi. What about the admission? Where will we admit? About in ICU or in our obstetric unit?
It is definitely an indication for ICU admission. She needs to be admitted.
Definitely we admit her. What are the treatment options, Dr. Achla?
The treatment option of this patient, because she seems to be in a severe COVID, so this has to be discussed with the multi-speciality. You know, we have to take into consideration the internal medicine or the critical care specialist, and in collaboration with them, the treatment would be done. The pregnancy will not affect the treatment option. Whatever treatment she requires, she has to get irrespective of her pregnancy. And if she does not improve in spite of treatment, you know, her oxygen saturation does not improve, we might have to consider terminating the pregnancy if she doesn't respond to treatment, oxygen, even intubation. If her saturation, hypoxemia is not increasing, then terminating the pregnancy might help her. Otherwise, the treatment for severe disease, the pregnancy doesn't change, it remains the same, only hypoxemia correction. If it's not possible, then we have to terminate pregnancy and continue with the treatment.
Dr. Biswajyoti, what about your opinion? When do you terminate the pregnancy?
You see, this is a 33-weeker who has come with fever and cough with deranged markers. So I am assuming that her oxygen saturation, she is already desaturating with such a say HRCT score level. So she needs an ICU admission probably. We should also involve the multidisciplinary, as Dr. Batra said, the complete multidisciplinary team, because it's I can only look after the baby. I cannot look after the mother at this juncture. She is now should be under an intensivist basically, and we should be guided by their decisions. We will of course do an ultrasound for the baby to find out whether there is any sort of IUGR, any sort of malpresentation or not. Indication for delivery will be only for obstetric indications, and only if the mother becomes severely ill that she needs mechanical ventilation, where the intensivist is asking you to deliver her to help them for their mechanical ventilation. In those cases only we will have to go for delivery. Otherwise, we would not go for delivery if there is any sort of fetal compromise or anything. If there is no fetal compromise, we would not go for delivery. Only if the mother becomes very severely ill or there is she is having a mechanical ventilation and she needs delivery for helping that mechanical ventilation, she is not coping with that well, I think in that cases, delivery is indicated. Otherwise, delivery is only for obstetric indications.
Yeah. Dr. Ajit, will she benefit by adding steroids? And what is the dose of steroids can you give at this gestational age and at this stage of COVID?
When this patient is actually desaturating, I'm quite concerned about this patient because anyway, we give heparin, this steroids, even consider remdesivir, all these things in this patient. And if she requires an invasive ventilation, definitely I have to go for a out and then go for the invasive ventilation. That gives the best result.
So definitely the recovery trial also says that steroids are definitely reduces the significant risk of mortality in patients, COVID patients requiring oxygen support, and they recommend prednisolone 40 mg orally once daily. And women who are not able to take oral medication, hydrocortisone 80 mg intravenously twice daily instead of dexamethasone was recommended by the recovery trial. So coming to the labor management, Dr. Aparna, now how will you actually manage, because this patient has is to be delivered, because all the esteemed panelists have said like she is desaturating and not maintaining. We need to deliver her. So what are the principles and how would you go with management of labor in a patient having proper COVID with a symptomatic COVID with a 4AD score of 18 by 25?
So, ma'am, I think there is some discrepancy here, because in this patient who's critically ill, I would not choose for a vaginal delivery in the first place. So patients, so here we have two conditions. So number one is patients who have mild to moderate disease. So those patients who are COVID positive, we can choose for a normal vaginal delivery and we can deliver them with all possible precautions. Here, the delivery protocols do not change and cesarean is only done for obstetrical indications. And the delivery should be done in a COVID designated place with all possible precautions for isolation, with good protection for the healthcare team, and also availability of support from the physicians or your critical care team available close by. But mostly mild to moderate disease patients can undergo delivery, normal delivery with good precautions. The monitoring in labor is very, very important. Oxygen saturation should be monitored. We do expect that the patients would be putting on masks, but sometimes it is not possible. So the healthcare providers should take adequate precautions with the adequate level of PPE. The labor monitoring remains the same. Continuous CTG is preferable because you would obviously not be using your stethoscopes to listen to the fetal heart. So a continuous CTG is definitely preferable. A good monitoring of oxygen saturation in labor is preferred. Epidural during labor can be offered. There is no contraindication to offering epidural. Otherwise, there is no change in the first stage or second stage management of labor in terms of monitoring. This is mostly about the labor management in mild to moderate disease. Again, we have to coming back to our own patient, which you have showed. If the patient is actually in case of a critical disease, I would again like to reinforce that 32 weeks is like a cutoff. Because most important thing is whether we can ventilate the patient adequately, whether we can make the patient prone. Because prone ventilation is something which is very, very important in a COVID patient. So SMFM guidelines also mentioned that cutoff is 32 weeks. Before 32, after 32, please make a good decision. And the obstetricians have to be really involved with the critical care people in decision making. So we have been involved in delivering these patients very actively. So you have to decide. Now, if the patient is ventilated, or even if it is not invasive ventilation, it is an NIV or HFNC, or if you think that you are providing adequate oxygen support, and even then the patient is not achieving the requisite, oxygen saturation, then she is more than 32 weeks, then it is time that you think of delivery. So 32 weeks is a cutoff. And despite adequate provision of oxygen through HFNC or even NIV, the patient is not. Again, mechanical ventilation is another, not an indication for delivery, because the guidelines evidence also mentions that even if you are able to provide adequate saturation, even with mechanical ventilation, then even then it is all right. But even if your mechanical ventilation is failing to provide adequate saturation and adequate ventilation, and you are more than 32 weeks, please deliver the patient, do a prone ventilation, and provide so that the improvement. And we have actually seen that the patients dramatically improve after delivery at more than 32 weeks. So 32 weeks is a good cutoff where you decide and get intensely involved with your critical care people, take that decision, because the surgical risk is not as much as we actually think. It is more that we need to deliver, get the baby out, provide a good prone ventilation, and provide good so that the patient can be ventilated better and the patients do recover with delivery after 32 to 33 weeks.
Yes, so very well put up. I think the delivery for the ventilation purpose, we need to assess. That is the individual assessment.
There is actually a definition called refractory hypoxemia, which we need to discuss with our own intensivists, and we need to see what is the ratio of PaO2 versus FiO2. Please look into it. People who are actually delivering, please get in consultation with our own intensivist, ask them what is happening. And if it is a refractory hypoxemia not responding to your usual ventilation strategies, it is time to deliver your patient.
So I completely agree with Dr. Sharma. That is one of the ways that we should be going by.
Yes.
Keeping the intensivist engaged is a very important thing.
I think very well put. I think about delivery and everything, all dilemmas must be solved. So now this all we have explained everything about delivery. Everything is well. Now coming after delivery, what about the newborn, Dr. Lakshmi? What about the newborn? Do we test the newborn immediately? I think Dr. Ajit would be better because he had done study about vertical transmission. So what about the newborn? Like how do we usually test immediately after birth? What are the guidelines?
The recommendation is anyway, it should be done only after 4 hours because sometimes there will be there. So at least within 48 hours, you have to do the testing of the baby. That is the way. Again, each institution may have its their own guideline. Our guideline is that within 48 hours you have to do it. It's better do it after 4 hours. That is the best thing. Then about the breastfeeding and rooming in, we recommend breastfeeding and rooming in. But of course, if the patient is critically ill and cannot breastfeed, then we have to go for a separation. Even such patients, actually, we ask them to express the breast milk because later we can give it. Or the same milk, if you use a dedicated breast pump or something, the same milk can be used for the baby. Then, if the baby is preterm, again, may need separation for that purpose. Otherwise, we don't usually separate. Again, we'll involve the patient. The family members also in making a decision, and if sometimes they are very reluctant to breastfeed, then of course we don't insist on breastfeeding. Otherwise, definitely breastfeeding is the best thing.
Yeah, Lakshmi madam, what is your take? Like, will you recommend screening?
Breastfeeding is if she is not critically ill, then breastfeeding should be advised. But the baby should be kept in the another room because mother and baby should not be in the same room. That precaution has to be taken. And all those who are taking care of this baby should take proper precautions, including the mother who is giving breastfeeding. She should take all precautions.
Yes.
The mother has to wear a mask and at least 6 feet away from the mother. You have to keep the baby. 6 feet.
Yeah,
6 feet is a fine.
Baby should be put in the cradle 6 feet apart. Yes.
Yeah. So we definitely, all the guidelines say that we need to give breastfeeding, but definitely keeping the baby separately in another room and a caregiver also wearing mask and feeding the baby hygienic way. That is what is recommended. And even they have said that even
keeping the baby in the same room but in a cradle, because after all the baby is going to go home with the mother.
Yes.
So if she is taking proper precautions, baby can be roomed in, but in the cradle, not on the same bed.
Same thing, that baby can be roomed in. The mother takes proper precautions and wears a shield or a mask all the time, the N95 mask. Definitely, even some guidelines even say that a mother can even breastfeed such if she not having a symptomatic, real symptoms of or any fever, she can even breastfeed that child.
Breastfeeding helps.
Yeah, helps. I think vaccination was discussed a lot, but what is your all take about vaccination? Do we still started recommending what is happening Aparna in Delhi, that all lactating mothers now, because lactating is now approved. So what is the scenario out there in Delhi?
Yes, so all lactating mothers are taking vaccination, and there is no problem with that. So it could be either Covaxin or Covishield. So no problem. Everybody should take vaccination. Pregnancy, we have to wait.
Yeah. So no, now it is started. All pregnant women are already started taking. What is the?
No. Pregnant women have not started taking. We cannot advise pregnant women. We cannot write for pregnant women. We have to be very, very particular that it is only allowed for lactating women as of now.
Yeah, because today I had got a call from a very senior colleague of mine, and he said that some doctor had, some patient had taken a vaccine, and so his patient was insisting a prescription from a doctor. She's a pregnant patient.
No.
Yes.
As of now, we cannot advise, we cannot write, we cannot advocate. Advocate, yes, but not prescribe and write.
Yes.
Dr. Kamal,
all over the world, it is given to the pregnant woman. So when I get a phone call, I only tell them, yes, it has been given, but Government of India has not advocating. So as of now, we have to follow the Government of India guidelines. So no doctor should give a prescription. No doctor can advise that you go and take a vaccination if she is pregnant.
Yes, because what happens, there are conflicting. They hear some patient somewhere, so they have been
not give, and if inadvertently she has taken vaccine and later on she has realized that she is pregnant, then this is not an indication for termination of pregnancy. She can continue with the pregnancy.
Dr. Biswajyoti, you wanted to add something?
Yes, I think most of the centers in Calcutta, what they are doing is they are making them fill up a form that they are not pregnant. And if the pregnant lady wants the vaccination, then they have to go for a doctor for a certificate, and no doctor is going to issue a certificate. So for pregnancy, we have to just assure them that it's your call. The Government of India hasn't approved the vaccine as yet. It's only for lactating mothers. It is, after all, but world over, it has shown that the risks, the benefits outweigh the risks. So if you want to go for vaccination, it's your call, not ours. We cannot recommend vaccination for pregnant women right now, as Dr. Sharma said.
Yes, definitely. There are guidelines still to come. I think hopefully we will have a recommendation for pregnancy.
There is one thing that
I would also like to add here, sir, that the vaccinating agencies also, vaccinating centers also cannot, vaccinate pregnant women as of now. So even if they go and they disclose that they are pregnant, they would be refused.
They will have to go to Singapore to get the
vaccine. They ask for a certificate.
Komal, I just want to add that here we have Dr. Parikshit Tank, and he is one of the member of the task force who prepared the FOXY GCPR about the vaccination in pregnancy, and it is freely available on Google. So please download it and read it. It has given the crystal clear stand of FOXY on vaccination in pregnancy. Yes, Parikshit is here. I have gone through it word by word, and it's a beautiful document about our FOXY stand on vaccination in pregnancy.
That is superb. So I think because a lot of messages are questions coming from the viewers regarding vaccination only.
They can download from Google and they can
comment at this stage. Dr. Parikshit.
Well, I think, this is the first time that, at least in my memory, that we've taken such a hard stand on an issue which is of public importance. However, we also are restrained by certain medico-legal restrictions. We cannot operate outside of what the government recommends. So as all the panelists have been emphasizing, that we do advocate and we do, hope that the recommendations will change. However, until that actually happens and the government allows us to use it, our hands are tied. So we have to abide by what the government and the MOHFW allows us to do. The moment these restrictions are lifted and the recommendations change, I'm sure that all women's healthcare providers, each and every FOXY member, will do his or her best to make sure that as many pregnant women are possible to cover, we'll cover them with vaccines.
And there was also some queries that every time when a lactating mother also is going to get vaccine, they tell that to get a doctor's.
No. Komal, this was only in Mumbai, where there was a move to get a doctor's certificate, but that has been quashed. That is completely uncalled for, really. That way there could be a certificate which is required for somebody who is having cancer, for somebody who has a heart problem. Yes. Then why aren't cardiologists, oncologists, etc., why are they not being asked to give letters? That doesn't make sense at all.
Yeah.
Yeah, exactly.
Definitely. When we should not, we should tell a patient is absolutely not required. When a government has passed a guidelines, you can straight away go and take the vaccine.
Yeah. We should not get ourselves involved in that.
So I think we'll just move ahead because we're just ending the panel. What about mucormycosis? Now, anybody has encountered any cases, because this is something which is the second wave and the black fungus. So anybody, panelist has any experience about this mucormycosis? Dr. Aparna?
No, actually, we have cases happening in AIMS. There is specific mucor OT, and a lot of patients who are coming referred to AIMS, but not in inpatient. So I think it is all about how we are managing. So these cases are not happening in patients being managed at AIM, but there's a lot of special OT being allotted to managing these cases. But yes, I think there are three things. It is something called an unholy trinity for mucormycosis, and I think prevention is the best bet that we have. So a baseline of diabetes with COVID with steroids. So if we take care that our blood sugars are controlled, and even if one dose of steroid that we have to take, and we ask ourselves that do we really need to take that dose of steroid. So I think that's the biggest thing and the biggest evidence that we have that it will prevent mucormycosis. So it is something that because steroid was used rampantly in this second wave of illness. So I think that is one of the biggest contributor to this particular problem. So if we just take this particular case and avoid this, take care of blood sugars and avoid even one single dose of steroid that we don't need, then I think to a large extent this can be prevented.
So, Dr. Aparna, can I ask you, have you encountered any mucormycosis cases in pregnant women?
Even I was going to come to the same thing. Anybody has encountered in pregnancy? Any case report or anything you have read about in pregnancy?
No, I have not.
I think still, I hope not we see more cases of mucormycosis, because I think this is more talk in town after the remdesivir. Everybody is in that amphotericin B. All the news channels are showcasing the shortage of drugs. So this is one of the thing. And the second thing, what about the maternal? I think we have discussed this when Dr. Parikshit was loading his slides about the second wave, and I think everybody has given the answers about increase in maternal mortality, wherein some cases they have seen, I think, increase. No, I think South. Dr. Ajit, yes?
Yes, it's increased.
You have seen the increase in maternal
much increased.
Yeah, much
compared to the first thing.
So let's wind up with the last take on the expected third wave, because everybody's scaring it is going to affect all the children, even the young children. So what about the third wave? Dr. Achla, when it is like anticipated, what are you hearing out there in Delhi?
Very variable reports are there. Some people are saying that 4 months, others are saying 6 months. We don't know, but definitely it will come, because that is how the course of disease have been in the previous infections also. But probably we'll be more prepared and we'll have less mortality and morbidity. But yes, to some extent, it is expected by the epidemiologist, maybe in November, maybe in January. We don't know.
Dr. Biswajyoti, you want to see any preparations done in Kolkata for the third wave?
No, what I think that the third wave is definitely going to come. Whether it is going to come just after the second wave or a few months later on, it's going to definitely come. The only way we can minimize the damage is by vaccinating. So that is the only way we can actually diminish the mortality or morbidity in the third wave. And regarding maternal mortality,
more than that, also keep taking the COVID precautions.
Yes.
Vaccination, more than vaccination, the COVID precautions are also to be there.
Yes.
Without that, vaccination is not going to help.
Yes.
Yes, of
that
course.
Is it. Dr. Aparna, you want to add like what preparations are there at AIMS, some extra care or something being done for the third wave, anticipating when
yes,
it is?
Yes, I think the COVID task force is hard upon it. The pediatrics department is very much active, not just in AIMS, and they have made protocols, and they're having a lot of sessions with pediatricians across country in anticipation and how you should be prepared for it. So hopefully it doesn't take the shape that is being expected, but yes, most of the neonatal and the pediatric units are being prepared with oxygen and the drugs. And because the most scary complication which is seen in kids and not in adults is the MIS. And that is what is really, anticipated to be very, very scary. So now a lot of complications of MIS-A is also being seen, the adults part. But the preparation for MIS in terms of the drugs, the oxygen, so a lot of infrastructural and also drug requirement and oxygen requirement is being anticipated, and there are actually proper structured preparations that are on for. I know this because our pediatrics department is playing a clean role in it. So hopefully we should not come to that, but yes, preparations are needed.
So definitely preparation is better because second wave came unexpected. So everybody is preparing for third wave. That is good, and hope we don't have a very like the second wave. The third wave should not be like a more fatal. So we expect good things to happen. So definitely with that note, we'll just wind up the panel, and with good things that we should keep up to date about the latest COVID information and guidelines from CDC, WHO, and even our government of India. Take preventive measures to control further spread, focus on symptomatic treatment, and breastfeeding is safe to the baby, and even express breast milk can be given even if mother is infected. Vaccination during pregnancy is a personal choice at present because there is a limited data. Whatever the safety is there, but there is limited guidelines which our government of India has to still approve. So definitely a pregnant woman we can give, and these are the references. And I want to end with a note saying, although the world is full of suffering, it is also full of overcoming it. This is by Helen Keller, and we know that everywhere there is suffering of COVID going on, and we doctors are actually trying to overcome this deadly virus and this pandemic so that we come back to the pre-COVID era very soon. With that note, thank you all for your patient hearing. And I think we have a lot of questions, some of which we have actually taken covered in the panel discussion. But I think there are almost 3,460 live audience. That message which I have read, so that is real phenomenal. And thank you all the esteemed panelists. Everybody is just glued to the talks.
But thank you, Dr. Kamal, for excellently moderating this panel.
Thank you.
It was an excellent panel discussion, and thanks to all the knowledge that we have imbibed today.
Yeah, I think we have covered most of the questions which were there, because I have seen my chat box full, but I think we have managed all about RT-PCR, everything. I tried taking one more. Okay, it's all congratulatory messages. So I think we have covered, in fact, as and when the questions were coming, I have just addressed to the panelists, and you have done a fabulous job. I think this discussion, COVID dilemmas, is unending. The more we discuss, the more people have doubts. So we just conclude the session, and I would like to thank the FOXI president, Dr. Alpesh Gandhi, who was also the chief guest, and he had come here with the esteemed presence, grace the occasion, along with Dr. Rishikesh Pai, the guest of honor, the vice president in charge for the committee, Dr. Atul Ganatra, Dr. Jaideep Khan, Secretary General, ICOG chairperson, Dr. Mandakini Megh and Parag Biniwale for the ICOG points, and all the esteemed faculties who have come, all very senior, eminent speakers, Dr. Ramni Devi, Dr. Bhaskar Pal, Dr. Parikshit Khan, who is also instrumental part of conveying this very, very nice and a successful webinar attended by so many people, and our esteemed chairpersons, Mr. Archana Verma, Anand Bagde, and all the panelists who have joined, Dr. Lakshmi Shri Kajla Patra, Aparna Sharma, Dr. Ajit, Dr. Bispujot Bua. Thank you so much, Team Science Integra, Team LMB. And also I thank Dr. Niranjan Chavan, who has helped me with some data from Sion Hospital and Sion Hospital, some data, and giving some data feedback about slides. So I thank you all.